Sujata madam, మీరు first.
Okay.
Sujata ma'am, please go ahead.
Good morning, everybody. This Sunday morning, we are all meeting here to discuss about this woman power in ophthalmology and conducted by our Andhra Pradesh Ophthalmic Society, and welcoming you all. We don't have any depth of woman power in India, especially in the field of ophthalmology. Future is present and future is ours. And we are going to discuss all the things here. And now I am handing over to Madhavi, and I'm thanking Dr. Madhavi and Dr. Madhu, our scientific committee chairman, and Dr. C.V. Rajgaru, and for giving me this opportunity to welcome all of you. Thank you very much. Dr. Madhavi, please take over and nicely conduct the meeting. All the best.
Yes, yes. Thank you so much, ma'am. Hearty welcome and good morning to all our esteemed speakers here. First, at the outset, I'd like to thank all of you for sparing your valuable Sunday morning with us. And we have a galaxy of speakers, all stalwarts in their own right, and such inspiring ladies. They're going to share their knowledge and experiences with us. Before we start, I also welcome Dr. C.V. Gopal Raju sir. He's our Secretary of APOS and also he's the Joint Secretary for AIOS. So sir, welcome you. I'm so happy you are here with us. Just put in a few words and then we can start our program.
Yeah, thank you, Madhavi. First of all, thank the scientific committee, such a dynamic committee, including yourself, doing a wonderful job and then maintaining that perfect schedule of monthly webinars. And second, I should congratulate you for planning such a wonderful meeting involving all the stalwarts in their own field. And also, we should be thankful to all those speakers who have readily agreed and spared time to participate in our program. This is the sample of how the future ophthalmology will be, and led by the stalwarts. Definitely, all these speakers are sort of a motivating future for all our young ophthalmologists. Not only females, including the males and including people like us who are already there. It's definitely a great session. All the best. Please go ahead.
Yes, thank you, sir. Thank you for your kind words. And yes, of course, behind all of us, we have men supporting us, no doubt about that. So here we go. So first, let us right away go to the program today. We have Dr. Madhu ma'am with us, Colonel Dr. Madhu Badauriya madam. She needs no introduction, but I would like to say, because it's such a proud moment to introduce her. She's the director of Regional Institute of Ophthalmology, Eye Hospital, Sitapur, UP. She's a graduate and postgraduate from King George Medical College, Lucknow, and a fellow at Shankar Netralaya, Chennai, entry segment. After working in the armed forces for a long time, more than 20-25 years, she has now become the leading force, and she has revived the Sitapur Eye Hospital. And she is a prolific surgeon in every field. It's made big cataract, oculoplasty, everything, ma'am, is there, glaucoma, all her interests. And she's our dear WAS president, that is the Women Ophthalmic Society president as well. She's an awe-inspiring woman. Welcome, ma'am. Please give us your talk. Over to you, ma'am.
Thank you, Sujata. Let me just share the, Yeah, let me just share this. So at the outset, let me thank Dr. Madhavi and APOS for inviting me for this talk. It is a little different than by and large we get to hear in ophthalmic conferences, but I guess it was taking it a bit longer for the slides to come. So with that, I've chosen a topic which is a little offbeat: the paucity of women leaders dealing with invisible barriers. Actually, truly, if we look at it now, first thing is, do we need women leaders? Truly, we do need, because earlier was empower a woman, empower a family. But I would say now empower a woman, empower an organization. Because with one lead woman come loads and loads of not so lead women. And we actually increase the productivity of the whole country, the GDP. We enhance collaborations, organizational dedications, fairness. These are very rich women quality leadership things which are usually under-acknowledged. It's unfortunate that less than 10%, only 7.5% companies are, the Fortune companies are led by women. So currently what's happening, there are lots of organizations which are working on gender diversity as a priority. They're setting aspirational goals, they're putting right proportion of women, they're insisting on diverse slates of candidates for selections, developing mentoring, training, everything. But ultimately, it's all leading to frustration. All the money, effort, intent all goes down the drain. And it's like, I love to show this equality slide. What they're doing is they're making men and women equal. Unfortunately, they're different. They're not equal or unequal. So like this boy doesn't need a stool, the girl needs a higher stool, and the person on wheelchair actually needs a ramp. So that is why this is exactly the way we will have to design now programs that will lead with the women to get into the leadership roles. There's so many women in ophthalmology, but look at the biggest of the hospitals of the country. Look at Shankar Nethralaya, Arvind, LVP, this side Shroff, CFS, look, any sector. Where is the lead woman? They aren't there really, like truly if you ask me. So current methods are not working because simple things like put them in a leadership role, give a skill, tell them to adapt to a style, it doesn't work. Because why? It's not working. Why? Because women are not able to internalize them within themselves as they are the lead, and the world is to follow them. So therefore, it's for them to see themselves as leaders as well as the others to see. And it's a very fragile process because it's very subtly invisible. And these cobwebs which we are having in our heads, I have to probably go out of the window. And let's start it now. Institutions truly they want to do it, but they inadvertently they are sort of creating path for men only. They advise women to seek proactive roles, but they won't change the practices, they won't change the job descriptions, they won't change the mindsets where people will accept them as leaders. So there's a mismatch how a woman should be seen and how they are being seen these days. These are subtle gender biases. They persist in families, they persist in organizations, they persist in societies. And this is from where there's a disruption in the learning cycle at the heart of women becoming a leader from the childhood. It's not enough to identify and instill the right skill. It's not to educate them, but they have to understand a reason why the woman has to become a leader. A woman has to become a leader at multiple levels. And then we need to fix a context or a reason as to why they should become a leader. And the motivators should be aligned with them. And for the women also, the motivators as per the evidence-based research are power, status, and curiosity. So our current methods traditionally that we are having these high-powered mentoring sessions, leadership sessions are all over the place, leadership training, but it's not working. Why is it not working? Because we're not looking at the finer aspects. What does it take to become a leader? It's different for men than women. Educate everyone, not only the men or the women, everybody, the whole society about the second generation gender biases. I'll talk about them a little later, and the purpose of leadership. So how to become a leader? The certain roles of self. So whether they are men or women, people become leaders by internalizing a leadership identity. It is altogether very different, and develop a sense of person. I have to do this job. I have to develop this organization. I have to reach the top. There has to be a particular purpose. They assert by taking small purposeful actions, like managing, Operation Theater, very simple thing, or then slowly these convert into opportunities. They become challenging assignments, like now an epidemic of endophthalmitis, and a person manages, a woman or a man, is a star or a hero, right? Like that, the growth happens slowly. It doesn't happen in a day, so we can't make these leaders. So now we have to instill practices that from the bottom, when they start into the practice, the leadership must start. But women are a little different. Men, even if they're not given a pat on the back, they're okay, they'll keep working. But women need a lot of affirmation and endorsement because they grow up suddenly, a little bit, what should I say, underprivileged. They have to be encouraged to come on the top, come out of the comfort zone, experiment with unfamiliar behaviors which don't conform in the society like a woman. And then even if she goes wrong, support her. Then they need opportunities to grow, and they need really a purpose that aligns with their personal values. So from the childhood, we need to teach them actually their personal values and how they can become leader in any field of life, including ophthalmology. So they need to have a broad vision. That's how they will start seeing compelling reasons that despite their personal fears and insecurities, they'll step out to become leaders. And if we really look at it, who is seen as authentic and trustworthy leader? The person who is able to take risk, not for self, but for others. All these CEOs of the companies or the CMOs of the hospitals, they always go out of the way to take risk for the whole organization. It's not their personal thing, you know. They need to be inspired. Their resolve has to be boosted. They have to learn to help colleagues and be helped by them. They must learn to seek help also and find deeper meaning in their work. And then only we should start judging them that this girl is a high potential or this girl is a low potential. So if we look at in the society, the common practices are really cut for men. They have powerful sponsoring males, whereas in women, there is a paucity of low lead women. We hardly have anybody. So we have to start looking at the leadership potential in a different way. We should look at it. The woman is more responsive to patients, to employees' needs. They avoid conflicts more easily. They promote collaborations. They have insight into problems and they can resolve actually without coming on the really forefront to fight it out. So we really need to recognize this, and so do the women need to recognize. Now, second generation gender biases, you know what, this is something which is actually plaguing our organizations today, not the overt ones. So these are like cultural assumptions. They're invisible barriers. We are not aware of it. Even the women are not aware of it. Cultural assumptions, organizational structures, the practices, the patterns of interactions, these are all inadvertently somehow put the men in the thing. You look at this interview table, the man is telling the woman clearly, I can't ask you questions which are prejudiced, but are you planning to have a family? If she's planning to have a family outright, she can reject her for the thing she's planning to have. So what is this? Is this a subtle barrier actually? So the three reasons for this is, one is paucity of role model women in the leadership. Then there's a gendered career path for men that has to be changed. Then lack of networking and sponsors by women, and double binds. So we really don't have. The young leaders need people to, as we say, is like emulation is the best form of experimentation or flattery. They need people whom they can emulate and experiment whether they are right or wrong. But unfortunately, they don't have. So after a while, they start feeling they're a little diminished. And sometimes because of this paucity, they even feel discouraged and they don't come forward only. Gendered career paths, if we look at it, a woman has to work definitely much harder than men to get the same recognition. So especially when we look in the hospitals, the administrative operational areas, there are not many women in them. Second thing is many men have trailing spouses who can go with them wherever, whereas I rarely know a woman whose husband would be able to trail behind. They'll be staying where they are staying. And the heroic front line, if there is something comes, the first thing people think of men and not really think of women. Women, I wouldn't say they're relegated, but they're given real value in the clinical jobs. So the head of retina is a woman, head of cornea is a woman, head of glaucoma is a woman. But when actually comes to looking at the leadership job, they have not done these operational jobs. So therefore, their QR falls short. Whereas nobody is looking at the behind the scene work like team building, skilling people, avoiding conflicts. All this is ignored. And if we don't have these kinds of well-built team by women behind their whole, all the work, can organizations run? Of course, they can never run. So lack of access to networking, this is actually a challenge. The guys have informal mentoring at a golf course, they will have it a drink, they will have it a smoke, they will have it a vada pav, but women don't have that kind of opportunity. If woman goes out of the way, then like people do talk. So this cultural assumption because of which women are, they really think is kind of a second-rate thing to network is something really bad, but unfortunately it's not really so bad also. And the important thing is that jobs are, leadership jobs are considered as the power jobs. And the power in this country at least is related to men. And if the woman exhibits power, then it's considered, yeah, she's very masculine or she's like this. And most important is that we are not sensitized to it. So women are also unaware that despite having all the qualities, they are either not considered or they're not even opting out for leadership roles. Truly, I'm telling you, women are equally responsible. They're not opting for these roles. So our remedial measures will be very simple. We educate men and women about the second generation biases. We create a safe place identity where the women can experiment and work. And we can anchor a purpose of leadership with their identity. So really, we need to understand how women behave. Generally, I keep hearing from the girls in the hospital, it's nothing over. I just feel a little less connection either with with positive or negative. And when I put my idea forward, it doesn't get traction. People don't support me. So it's nothing else. It's just that they're not connected there. Nobody is really out to harm them. So women recognize these subtle and pervasive effects. The moment they start recognizing, they feel empowered. And once they feel empowered, they can take actions to counter those, put themselves forward for leadership roles. They can seek out sponsors and support. They cannot go for a vada pav, but they can always go in the conferences. They can meet people in conferences. There's so many things like where the hospital meets, dinners, lunches, meeting people outside. It's really not a big deal. They can negotiate for themselves as well as in their personal and the organizational goals both. Small wins need to be celebrated in case of women, at least till now. Small little change in the job description. I'll give an example. I had a girl engineer whom I had a project manager. She had no idea about it. Now, the little what was required was in the projects and all, you got to go a lot on the field all the time. You got to be on the biking, on the vision centers, outreaches, this, that. Little change made the job hybrid. Part of it could be done with the Zoom calls, internet, part of it could be done by telephones, and part of it by things. The girl is a super top star. She's been lifted from our place because obviously the good people are lifted from the not-for-profit organizations. Then we must learn to promote their talents. We've got to look into their minds as to what is their talent and where they're really good at. And believe me, when you look inside, there's so many talents. And we need to give them equal roles in the strategic and operational areas. And that is something has to be inbuilt from the time they join the organization. Safe place, we don't really have safe women place as on now. And women on top are scarce only because they're averse to visibility, scrutiny, and risk-taking capability. So till such time these women come on top, we have to have mixed places which are safer for these women, like where they can experiment. Community is very critical. So if they make a mistake, so what is the big deal? Anybody makes some mistakes, it's all right. Take it in a stride. So we need to have men and women, both genders supporting at the moment. Competence and likability for women is different than of men. So therefore, this is also a gender difference that we need to understand. It's not a weakness, rather it's a strength. So core strengths of women are a little different and we need to recognize them. And women also need to have a clarity. It's not that every woman is cut for leadership or every woman wants to go for leadership. So they have to decide also that do they really want to be there or otherwise be in the whatever role they're doing it. So normally when we look at it, the leadership programs and the assessments in the organization. When you put the women through leadership program, the usual result will come. They exceed the goals, they act decisively, they take feedbacks, they use, and they're very effective. When you take an organizational assessment, 360-degree, it comes as they're meek, they're timid, their decision making is poor. So there's a actually big mismatch. And it's because of gender stereotypes. Look at the women, not the way they are, but the way their mind sees. So we need to change glasses also. So now what we really need to is, we need to design the leadership programs, women specific. We need to create safe coaching places for women. There got to be men or women, whosoever is available, who can coach them and support a group of peers. And these communities, they don't have to be on the spot or in the organization. They could be actually online communities like everything else. And then we need to link their purpose. Purpose is the most important thing. The moment purpose is clear, focusing on a skill becomes easy. Connections start proactively. Normally women think, this is not a my interest, so why should I do it? But the moment you think that you doing this will help your purpose, they will start doing it. And same thing is also for networking. Generally, women feel this networking is transactional. They're not genuine. And women are by and large at heart, they're very genuine kind of people. But the moment you think that is not for you, you're doing for a purpose, automatically it becomes naturally, you become less diffident about doing it. So learning how to how to be an efficient leader, it is really a very complex skill. We were told always leaders are born. Unfortunately, leaders are not really born. The leaders are made. They are made by themselves and they're made by the organizations and the team around them. Start small surveys, a small technique, a small innovation, and slowly successfully transition to the senior management role. But here it comes a huge price that we all must know we need to pay. A more successful clinician, when it becomes a leader, has to let that go. So shedding previously effective professional identity is the most painful part. Let me tell you, I've been through it, and most of us who are in those positions, who are heading the organizations, know it, that you got to let go something that was most dear to you. So sacrifices also comes automatically. And then you develop a new and befitting role. So to conclude, I would say, encourage women to anchor to their leadership purpose. The learning must be accompanied by a growing sense of identity as a leader, and not as a skill, but identity as a leader inside that I am the person, I got to do this. This is going to be my role. Focusing exclusively on acquiring new skill is not sufficient. Second generation biases are there. We need to know ourselves and we need to sensitize everybody around us. That is why greater understanding of gender biases is required, and safe spaces for leadership identity development. If we can do that, then believe me, will not be dearth of leaders, either men or women. And what I've said is actually a lot true for both kind of leadership, men or women. So thank you so much. This is the kind of environment we create. We'll have no dearth of leaders. Thank you.
Thank you so much, ma'am. Wasn't it really invigorating and awe-inspiring? I think all of us have a leader in us. It's just to be tapped. It's waiting for us to harness our own skill set and our leadership qualities. Thank you so much, ma'am, for that motivating talk. So there's a slight change in the program. Instead of going on to the next topic in oculoplasty, we are going to have the second keynote address by Dr. Namrata Sharma. She's going to talk on phaco in corneal opacities. Dr. Namrata Sharma madam needs no introduction at all. She has done a tremendous job as Secretary AIOS for the last 3 years, and then now she's the Chairman Scientific Committee. She's a professor at RP Center, All India Institute of Ophthalmic Sciences. Welcome, ma'am. We are indeed proud to have you amongst us. Over to you, ma'am.
Thank you so much, Madhvi, and I do apologize for this change which has occurred, and especially for the next speakers. It is always a pleasure to listen to Dr. Madhu Bhadoria, ma'am, and like always, it was very inspiring, and a lot of, I think, the practical difficulties and the practical problems which are more within us, as she also emphasized, are some things which need to be looked at. So I would be talking to you about a topic which is again close to my heart as far as clinically it is concerned, because I work in both cataract and cornea. And there was a time when this topic was not so common, but now it has become common, and more so in between, because we were not getting cornea. So we thought we have to do something in the interim procedure. So I would be talking to you about cataract surgery in corneal opacities, and there are no financial or proprietary interests. I have discussed the off-label use. Trypan blue is now, of course, not off-label, but air is off-label, and the use of air as off-label. So the bigger question always is whether you would want to do a cataract surgery alone, or you would want to combine it with corneal transplantation. And it will depend upon at what level the corneal opacity is and what is the location of the corneal opacity. So if it is peripheral or paracentral, one would do a single stage cataract surgery. But if it is central, then one can combine it with anterior lamellar keratoplasty, posterior lamellar keratoplasty, or full thickness keratoplasty. In these cases, it is always preferable to put a monofocal intraocular lens, and IOL master is often not possible. So you have to do take the keratometry, which is standard, or take fellow eye, or do a peripheral video keratography for the keratometry part to calculate the power. Now, this is essentially what the whole talk boils down to. That is, if there is a small central corneal opacity which covers only the visual axis partially, then you do phaco alone. But if it is a small central corneal opacity which is covering the visual axis, then you do optical iridectomy. You may get away even with superficial opacities with PTK and phacoemulsification. But if it is, like I said earlier, involving any layers of the cornea, then in those cases, one has to combine it with the corneal transplantation. And this is the review article which we published in Journal of Cataract and Refractive Surgery. A word about Fuchs dystrophy, because there's always a confusion as to when to combine it with cataract surgery. Important thing is visualization. So if you view it well, it is always good to do a phaco first and then take a call later on whether you want to do endothelial keratoplasty or not. Sometimes you don't need to. And also corneal thickness and cells will be a guide which will tell you whether you have to do a combined procedure or not. But I think the key thing that is there is visualization from the cornea. So you have to plan your incision, because you have to become half phaco surgeons, in the sense you have to do the entire phaco from one half of the cornea, which is clear. So plan your incisions on the site where you would be able to see the phaco probe, IA probe, etc. So just to give examples, this is trypan blue staining in a case of chemical injury. And as you go underneath that opacity, you'll go in one go, because you can't afford to lose it there. This, of course, is not a very bad opacity. Even if you lose, you can pick it up, but sometimes it can be really difficult. Hydro maneuvers, I would always say you should do very vigorously. Of course, you have to rule out posterior polar, because that kind of helps in loosening your nuclear epicortex as well as your cortex matter. And then if required, you can also put a suture in the end in such cases. Now, this is a case of dry eye, healed keratitis, and the only seeing eye, because the other eye was lost due to corneal transplantation, following which the patient had infection. So he wanted only cataract surgery, and notice that as you go underneath that opacity, you have to go in one go, or you have to push the globe a little bit down to see that edge of the capsular rhexis and make it a little eccentric, because that is the area of your visualization. There's an optical iridectomy also there. So that is also from the area from where the patient will see. It is an eccentric crater. It is not a central crater. And do phaco in situ, which means that as you chop, you eat, you chop, you eat, because what happens is that your retroillumination will get better and better and will allow you to see better. Also, always remember to put your retroillumination on in such cases, because that is a very, very big tool that you have to allow you to see as the surgery, as the surgical steps are covered. There may be some fragments which may be getting camouflaged under this. So you have to lollipop it inside your phaco IA probe, and then one edge of the margin can be seen here. So intraocular lens placement can also be done. We've also tried eccentric IOLs in these cases, where we've got customized intraocular lenses made from the care group, and I have no financial interest, so that this part of the cornea becomes clear. And as soon as you put intraocular lens, it'll become much clearer than what it was before. Now, this is a case of small pupil, hard cataract, dry eye. So you expand your area of visualization. So put nylon hooks. Again, notice this is temporal, because this half of the cornea is clear, and this is a hard cataract. So again, trying to make an eccentric crater and follow the same principles which were described earlier. Now, sometimes in the soft cataract, this is the opacity which is there. So you make peripheral chops and kind of paralyze it peripherally. And once that nucleus is made a little looser by those peripheral chops, the springy action of the peripheral part, it goes away, and then you can manipulate it. Just to show this, in this example, there's a central corneal opacity which is present. Rhexis has already been done. And as you do this case, make peripheral chops. So once you make peripheral chops and leave them there, the springy action of the nucleus, where it doesn't allow maneuverability, goes away, kind of gets paralyzed, and then the peripheral part can be emulsified, followed by the central disc, and followed by the intraocular lens implantation. Then sometimes you think this is hazy, but this is not hazy, because there is a pannus there, and cornea surgeons would know how to recognize this. And for that matter, there's no rocket science. Anybody can recognize the pannus which is there. And whenever it gets blurry for that moment of time, just put a blob of viscoelastic, because for that spur of a moment, it'll become clear and it'll help you to initiate the step, which you can do and may have to do intuitively in some of these cases, especially when there is a haze. Now, in cases of ocular Stevens-Johnson syndrome, we have again published our technique of cataract surgery, and this is a Sja syndrome. Now, this is a high risk for corneal transplantation. So in this case, nylon hooks are being implanted. Then you can see chopping is done with the endo-illuminator inside, and then the incision is temporal. And now the endo-illuminator is outside to see the margin of the rhexis, so that the foldable intraocular lens can be implanted. And they will not get 6x6, but they'll get good ambulatory vision. Now, again, endo-illuminator and chandelier has a role to play, especially when it gets very hazy. And again, in this case, the nylon hooks are being put, the trypan blue staining of the dye is done, capsulorhexis is initiated. Now the endo-illuminator is inside, but sometimes you may not be able to see, so you may have to use a chandelier. And with the endo-illuminator, you can see that there's total internal reflection. And so assistant has to be very smart to see where you're operating and to help you in this surgical maneuver. And this is, of course, followed by a foldable intraocular lens implantation. This was a very tough case. In fact, was posted for DSEC surgery, and notice that this was a case in which there was a cataract also present and a membrane also present, which was there above the cataract, which actually was realized later in the surgery that this membrane is present after putting the IOL also. And then chandelier again was used in this case so that one could see where one is operating. The view is not very good because this has been done under 3D and then we are trying to show the video under 2D. But this is the post-op picture, so one can see that again some amount of vision the patient has. So these are just pictures to show that you may have counting fingers at 1 meter, but you do become 6'12", and counting fingers here again 6'12", and here it is again, it doesn't look, it's a total white cataract, and patient does get some vision post-operatively. And these are the cases from our series of SJS, where we didn't want to touch the cornea because SJS cornea just melts away if you do any kind of surgery. This is not a very good case, but then okay, from hand movements, it makes a lot of difference in the quality of life of the patient. Now, femto cataract plays a very important role in corneal haze because it helps to fill in the gaps. It will not cut at the area where you want it to cut because there would be haze, but it doesn't matter. It has kind of made a spoke here. It's missed here because there is haze there, or it misses the rexes here because there is haze there. But that doesn't matter. It kind of you can just fill in the blanks or fill in the gaps. Whatever femto has done, that's a help. And whatever femto can't do, we do it mechanically or humanly. And this is just to show how femto cataract, again, notice that here you have these chops, but this area there is no chop. You don't have a rexes here, so you just fill in the blanks here, and it kind of helps because it has done at least something. This I will show you very quickly. I know this is not under the realm of cataract surgeons, but this was never planned for a cataract surgery. This was planned for a DALC, and we saw a cataract there. Again, a one-eyed patient with one-eye phthisis bulbi. So we did cataract surgery as well as we did DALC in this case. Important thing is that don't do DALC on a bare Descemet's membrane because that will perforate. So leave a little bit of stroma, then do cataract, and then come back and remove the last bits of stroma which are there on the Descemet membrane, and then do a graft. So the patient is happy with the vision. And this case I like to show, although it's a very old case, but this just tells you that this patient was referred for penetrating keratoplasty, and we just removed the epithelium to see what is there. It was hypertrophic. Then we saw Descemet's membrane, which was completely scarred. So this was a advanced case of Fuchs dystrophy. And then we did a anterior capsulorhexis, followed by phacoemulsification, followed by foldable intraocular lens implantation, and followed by DSEC graft, which is pulled intracamerally. And then this is now almost 7 years down the line. So you really don't need a full thickness graft or sutures. And you have to sometimes plan these cases well to be able to discern that. This I think I will skip, but just want to show that in a case of Fuchs dystrophy, you can even do DMEC. And this is how it looks. And after a month, you can't even make out that you've done a DMEC as well as a cataract surgery. It just looks like a cataract surgery case. So results of DMEC triple, again, if done in early cases, are very gratifying. This is too complex for the general ophthalmologist. So I think in phacoemulsification, the dictum is finding, seeing, creating, and filling the gaps. So incision placement has to be planned. Capsulorhexis has to be eccentric. Some of the cases, crater may be eccentric in some of the cases. Peripheral chops may help to paralyze the nucleus before emulsifying them. You may have to do sphincterotomy, optical iodectomy for the patient to be able to see in the end. And I think that is a call that you take at the end of the procedure. If the patients are high risk for grafts, do a phaco first. If they are good prognosis for grafts, do combined procedures. But prognosis is that you have to tell the patients that they're going to become ambulatory. And I think counseling is extremely important. Having said this, in almost 80% of the cases or 75% of the cases, I would always do a phaco first and take a call for the grafts only later sequentially. Thank you very much for your kind attention.
Thank you so much, ma'am. That was such lovely videos just goes to say that we need not write off any case. We need not say very bad prognosis, nothing can be done. No, something can be done for every case. Just that we have to do a little more of homework, plan the procedure, and then go ahead. Anyone has any questions for ma'am? Because I think ma'am would be leaving us shortly because she has to go for DOS meeting. Then we'll go on with our regular schedule. So next we have Dr. Kasturi Bhattacharjee. She's going to, let me introduce her first. She is done her MS DNB and FRCS from Glasgow and also FECO in orbit oculoplasty. She's a director of clinicals and academics and head of the Department of Cataract Refractive Surgery, head of the Department of Orbit, Ophthalmic Plastic and Reconstructive Surgery and Oculofacial Aesthetics at Sri Shankaradeva Netralaya, Guwahati. She's an all-rounder, I would say. She's also the AIOS member ARC East Zone. And also recently she has won the election and she is the president, incoming president for the prestigious Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery. So we indeed have a luminary with us here. She's going to talk about oculofacial aesthetic surgery. Welcome, Dr. Kasturi, ma'am. Just give your talk.
Thank you so much for the invitation, Dr. Madhavi, and also all members of Andhra Pradesh Ophthalmological Society. Can you see my slides after
Yes.
the beautiful
Yes.
talk? Like I'll be talking something different, but I hope that all of you enjoy it. So I'll be basically speaking on periocular aesthetics in oculoplasty. So when we talk about the periocular aesthetics in oculoplasty, the most common surgery that we do are basically the blepharoplasties. Next comes the injectables, and the third comes the thread. So what is this blepharoplasty? This blepharoplasty is basically a surgical procedure in which variable amount of the skin, the muscle, and the fat, which are being either excised or it is being redraped and it is being sculpted. So it has come from the word blepharon, which means eyelids, and plasticos meaning the lid. And if you really look to, like in not only in Indian scenario, but if you look to the Asian scenario, today it is one of the most time-tested surgical technique, and it is being done in the highest number in the Asian countries, more than that of the cataract, both for cosmetic and functional indications. So this is a very simple surgery where you need to mark the incision, and there are different rules, the rule of 10, the rule of 8. Like the best is if you follow the rule of 10, where the lower incision you keep a 10 millimeter from the eyelash, and the upper incision another 10 millimeter from the eyebrow, and then you excise in layers. Definitely first the skin, and especially when you have a thick lid, like in Indians, we have too much of hooding, we have a thicker lid, then you can remove some amount of the preseptal orbicularis, and then you need to incise the septum and find out the fat. So when we look to the upper lid, basically you'll see there are two groups of fat in the upper lid. One is a central, one is a medial. And the origin of both are different. The medial comes from the neuroectoderm and the central, which comes from the mesoderm. Very interestingly, when I started doing this blepharoplasty, all these fats now, I have started doing a stem cell culture, which I also published it, where I have found that as because this medial fat comes from the neuroectoderm, you can also have transdifferentiation into osteocytes, the chondrocytes, and most important, our paper had also shown that it can undergo neurogenic transdifferentiation. And I'm sure Dr. Namrata is there. You can work for a translation, and you can sometimes use it for ocular surface disorder. So this is what has something very interesting has come in my journey of doing a blepharoplasty. So the end point of the surgery is slight eversion of the eyelash. So this is followed by, closure of the skin. So what I want to show you the end point, you can see this eye has been operated, the eyelashes are everted, and the other eye which is not operated, you'll see the eyelashes are still straight, and you need to do the same procedure. So what are the indications? Yes, we know the most common indication, especially in Asian eyelids, is to redesign a single eyelid fold to a double eyelid fold. But there are lots of functional indication in the form of epiblepharon, the lash ptosis, the dermatochalasis, and the lateral hooding. And this is which a classical example of a aesthetic blepharoplasty, wherein we do a blepharoplasty to redesign the eyelid fold. And this eyelid fold which needs to be there in both the dynamic and the static gazes. But what are the other indications? The other indication, one is definitely lash ptosis, where you do a upper lid blepharoplasty and redirect the eyelashes. And the next common being the epiblepharon and the dermatochalasis. What happens in such situation? The eyelashes will keep on touching the cornea, which leads to ocular irritation. These releases the MMP9 and other inflammatory mediators like the cytokines, increases the osmolarity, reduces the tear secretion, and this whole vicious cycle will keep on going. So there are lots of reports where the blepharoplasty helps in situation like dermatochalasis, where the overhanging skin, it blocks the light entering the eye and causing diffraction. So this is a very common indication, functional indication, and more than that, especially when there's lash ptosis, it causes reduced temporal field of vision, which we have published. You can see before and after in 60-4. Also, it helps in the correction of some amount of astigmatism. But the most important here, like there are reports, and we have also published, where we have shown the effect of blepharoplasty on Zernike's polynomials, where you see both the horizontal and the vertical coma. You can see this gets much reduced before and after the surgical procedure. That is, it really helps in the quality of vision. So this is about the upper lid, but when we talk about the lower lid aesthetics, it is basically to tackle the tear trough and the ibex. So this tear trough in our terms, we call it more of a valleys, and the ibex, we call it more than the hills. So what causes this? This is because of the conversion of this positive to the negative vector. So what is this positive vector? If you look, because we have a very good maxilla in a very correct position. So when we are young, you look to the green and the right, the malar eminence is much anterior to the plane of the cornea. So this is known as a positive vector. And as we age, because of the bony resorption, the retrusion of the malar bone, so this malar bone comes much behind the corneal plane, and this is known as a negative vector. So because of the topographic bony change, which we call the differential uneven site-specific bony resorption, along with the soft tissue changes, we get lots of periocular changes, which leads to a negative vector. And the most common periocular changes being the eyelid bags, the next being the malar mound and the festoons, which we call it as a double convex deformity. Then the other periocular aging changes can be number one, the horizontal lid laxity, the dermatochalasis, which I have already mentioned, the presence of the tear trough, and the periocular rhytidosis. So how do we manage each one of them? This periocular rhytidosis can be managed very well by injection botulinum toxin, which gives a really wow effect. This effect you see within 2 to 3 days following the injection. And these are some of the FDA approved indication, whether it is for crow's feet or for a forehead line or the glabellar lines. As you can see here, but what happens, how do we manage the valleys and the hills that I have already mentioned? It is best managed by injection dermal filler. So this is basically a hyaluronic acid that we inject into the tear trough, which can be injected in different techniques like the puncture, the antegrade, retrograde. But what we commonly follow is a fanning technique, and it is a very safe technique when you go in the appropriate plane. So when you look to the tear trough, like you can see, no, this is the tear trough. It can be managed very well by the dermal filler, where the shadowing effect is being much reduced. But when you have situation like some amount of fat herniation, so do you go for the surgery or you go to fillers? So if you have this fat, especially the medial fat being herniated, and when this fat lies much behind the plane of the anterior lacrimal crest, so these are the situation which can be managed non-surgically by injection dermal filler. And this is a young lady where you can see the fat is being herniated, especially the lower lid, more of a medial component. So once you assess it, you try to inject the dermal filler. And the safest, even for the beginners, I should mention, never use a needle. It should be always a cannula, because the tip of the cannula is blunt tip. The product comes from the side of the cannula. So chances of any vascular complication is much less when you use the cannula. So along the inferior orbital rim, that is just below the orbitomalar ligament, you inject the dermal filler and you see the result. See the result before, how beautifully this whole fat, get concealed, and this is just a day following the surgery. So this dermal filler conceals the fat and corrects the tear trough, and not only that, it converts this negative vector into a positive vector. So there are multiple situations where you'll see the small amount of fat along with a very prominent teardrop. On the table, you will be seeing the change following injection dermal filler into the teardrop region. Like sometimes you see it on the table. This is just site of the injection of the, the entry of the cannula, and you see the whole of the fat and the bag is being much reduced following the procedure. So this is another case where you see now you see the fat has gone much beyond. It is not only medial, it is involving the whole of the lid. So in such patient, what we do, we also do sometimes a limited blepharoplasty, and this is being followed by dermal filler, and you see the change. She looks like a daughter to herself. Like this is how she came to me, and this is how she looks now. So there are different advantages of dermal filler, but if you have something like this, where the whole of the lid is lengthened, you have all fat, the fat is so much exposed, which lies much anterior to the plane of the anterior lacrimal crest. So this is the situation where you do a lower lid blepharoplasty. So you need to do the surgery, and here in the lower lid, we have the 3 fat bed, and you have a very important structure, the inferior oblique muscle between the medial and the central fat bed. And this is how, if you look in a 3-dimensional view, how the medial and central is much anterior as compared to the medial and the lateral, which is much, much deep inside the orbit. So being an aesthetic surgeon, you have to do something which does not give any scar. So I prefer doing through a transconjunctival approach so that you will not be able to make out whether the patient has gone any surgery. And the most important part for us, we should try to keep everything natural. So this is a transconjunctival approach where you can see all the 3 fat beds are being exposed. Most important is that you need to form a fat pedicle. So now this fat pedicle will not excise it. With this fat will be used as a filler. And this is that important structure that I was mentioning, that is the inferior oblique muscle. You should be very careful not to damage this muscle so that she doesn't or he doesn't end up with a postoperative diplopia. So these are the 3 fat pedicles. Now this fat will not be excised. You need to transpose it, use it as a filler. And before transposition, what we need to do, we have a very prominent ligament, which is a true ligament, that is an osteocutaneous ligament coming from the bone and inserting into the skin. So you need to release the ligament. And once you release the ligament, what you do, you use this intraorbital fat and place it down into the mid-face zone, which we call it beyond the SOOF. So you place it down as possible. This will really give a very good volume enhancement. So this is an animation showing all the 3 fat pad, and the 3 fat pad, you can see I'm not excising. This will be transported layer by layer as down as possible to the mid-face to give a very good effacement of the late cheek junction and to correct the, hills that I was mentioning. So this is you see before and after the surgery, this effacement, the late cheek junction, and she looks so natural. You can see how this conversion of the negative vector into a positive vector following the lower lid blepharoplasty along with the transposition of the lower lid fat. So conversion of this negative vector into a positive vector, which gives a much better look following the surgical procedure. And I feel that this also has a functional indication. Sometimes what happens, these people, they come to us with constant epiphora. You do a syringe in, there's no improvement. Because of the fat which acts on, pushes on the orbicularis muscle, the lacrimal pump function is decreased. So you do a very good blepharoplasty and invariably the epiphora gets corrected. So I feel that this also has got a functional indication along with the correction of the aging change, that the correction of the negative vector to a positive vector, as you can see here. So before I complete all this, I'd like to show, like, this is a lady who had also got a little amount of a facelift, mid facelift, only the middle group of muscle I have used. This is how she was before the operation. And now you see the transformation after the operation, but looks so natural and so refreshing. Little bit of the other new things that we also do as an oculoplasty surgeon, we also use the thread. I feel the thread is very good. It is an office procedure because many people, they do not like filler because the face swells up. So this thread can be different material, but for me, the most common indication is basically a brow lift. So in some patient, sometimes even in young patient, I see because of genetic factor, the brows are in a much lower level. So these patients, they do very well when you put this cork thread and pull it in the direction of the main vector. And then on the table, you will see the very subtle elevation of the brow, but they really, like, she is not very old, she's in her early 40s, and you see the brows are much lower. And this is after the procedure where you can just subtle changes, and also there's no swelling, nothing, just an office procedure, and where you can see this definitely improvement. Sometimes people come with very heavy, high eyebrow. So these are the patients who really do very good with thread. We use different types of thread. As you can see on the table, you can see the correction of the eyebrow. And this is what you see before and after the surgical procedure. And sometimes what I do along with blepharoplasty, I put some amount of the thread. And this thread, a very simple thread, which advantage of thread is also it causes the collagen synthesis. So along with it, it really smoothens the skin. And also after a few days, you'll see the results are very good. So different types of thread, this is not a painful procedure. Along with the blepharoplasty, you can do also a very minimum amount of a natural looking, the eyebrow lift. And these are some of the procedures which I nowadays routinely do with my blepharoplasty. So before I conclude, I really like to mention that for all aesthetic procedure, we really need to do a very effective preoperative counseling, documentation, and also most of the patients, we have to make them explain that the downtime can be as more as 2 to 3 weeks. And I always believe that the main objective of any aesthetic procedure is a critical reflection on the natural appearance, the self-esteem, and the self-confidence. So before I like to mention that all the aesthetic procedures have a functional indication, and all functional procedures have an aesthetic requirement. Just like how we have stepped from ECC to SICS to less than sub 2 millimeter for phaco, because we do not want to have such a big scar. Exactly, all functional procedure that we do should be considered to have an aesthetic indication. Thank you very much for your patient hearing.
That's indeed an eye-opener. Very beautiful talk, Dr. Kasturi. So yeah, so many of our patients really do come for this. Then we try to look at only the cataract or depending on what we are doing. But there's so much of indications for oculoplasty and aesthetics. We totally get it. So nice, beautiful presentation. We'll have one more talk on oculoplasty, and after oculoplasty and Proptosis. Dr. Anasuya is going to talk on that. After that, we'll have a short discussion. So now for the next talk, we are having Dr. Anasuya Ganguly Kapoor. She has done her, I think she also needs more introduction, but then nevertheless, she's done her MBBS from Nilratan Sarkar Medical College, Kolkata, and her post-graduation from All India Institute of Medical Sciences. She did her 2-year fellowship from Ophthalmic Plastic Surgery, Orbit Ocular Oncology and Facial Aesthetics from the prestigious LV Prasad Eye Institute. And she's also a DNB diplomate of a national board. She has been in Vijayawada, leading the Himabindu Elementary Center for Eye Cancer and eye cancer at LV Prasad Vijayawada. But she has done such tremendous good job that she has been promoted as the head of LV Prasad Eye Institute Vijayawada since 2021. Under her able leadership, the campus has really seen phenomenal growth. We are all seeing that, Ansuya, your name is heard everywhere, all over here. Welcome to this talk, through this program. Please deliver your talk. Thank you so much for being with us, Ansuya. I know you're very busy.
Well, thank you. Thanks a lot, APOS team, Madhavi, Madhu, and Dr. Gopal Raju for having me here this morning. So my talk is I have named it, the baby's eyes is bulging. And so in our clinic, we hit a diagnosis or we miss it, but every time we learn. So today I will be emphasizing few of the key clinical features in dealing with pediatric proptosis. So this 1-year-old baby came to us with left eye swelling since 1 week following upper respiratory tract infection, which is a very common scenario. And on performing an orbital imaging, which is must for all cases of orbital cellulitis, homogeneous patchy soft tissue density was noted more so in the medial orbit, along with the associated sinus involvement. So this is a case of orbital cellulitis with the subperiosteal medial abscess, and the child was doing great following IV antibiotics and abscess drainage. So how do we differentiate a preseptal from an orbital cellulitis? Proptosis, decreased vision, and ophthalmoplegia are the three clinical signs we need to look for to differentiate orbital cellulitis from preseptal cellulitis. And if we diagnose as orbital cellulitis, the patient should be preferably admitted, and orbital imaging needs to be performed in all cases, and IV antibiotic needs to be started. Whereas a preseptal cellulitis can be treated on OPD basis with just orbital antibiotics. So although this is the most common clinical scenario in our OPD, all pediatric proptosis are not orbital cellulitis. Like, all these patients have different diagnoses and key clinical features if we observe in the OPD that will help us diagnose appropriately. So in the next few minutes, I will be highlighting the key clinical features in all these cases. So this 10-year-old girl was brought to our clinic by her parents with prominence both eyes since 1 year. The parents were extremely worried, but the child had high myopia. So this was nothing but a pseudoproptosis. So in such cases, just measuring the axial length helps. So beware of pseudoproptosis, ipsilateral eyelid retraction, ipsilateral macrophthalmus, contralateral ptosis, or inophthalmus, microphthalmus, or a shallow orbit. All these can cause pseudoproptosis, and we need to be aware of it. Moving on to this girl child who presented to our clinic with acute proptosis in the left eye. This was preceded by an attack of upper respiratory tract infection. So now what is this? This is this is the CT scan picture, ill-defined multiple heterogeneous cystic masses. There are, and it is transcompartmental, that is both in the intraconal and extraconal compartment. There are air fluid levels present. So this is nothing but a typical case of venolymphatic malformation with bleed. We just need to go in, aspirate the blood, and do a bleomycin sclerotherapy. So sudden intraorbital hemorrhage in a child, think of venolymphatic malformation. Moving on to the third case, a 3-year-old boy came to our clinic with left eye vision drop since 12 days. He has already been treated with intravenous methylprednisolone with a diagnosis of thyroid eye disease, which is absolutely not the case. The left eye, you can also see that there is optic disc edema. And this is the CT scan picture. We see homogeneous soft tissue density in the superior orbit and spreading till the orbital apex and causing a compressive optic neuropathy in the left eye. So whenever, this particular clinical picture is absolutely indicative of a granulocytic sarcoma or a myeloid sarcoma. So we just need to go ahead and do a peripheral blood smear. And similarly for this patient, it came out blast cells were seen. So it was a case of acute myeloid leukemia. So rapid onset proptosis with subconjunctival hemorrhage with bilateral soft tissue homogeneous density on CT scan. We will have to rule out myeloid sarcoma. Just do a peripheral blood smear. Incision biopsy is not required if peripheral blood smear shows the blast cells. However, for this 6-year-old boy, although there was this acute onset proptosis and we see the superior orbital mass similar to the last case, but the peripheral blood smear in this case was normal. So we had to go in, do an excision biopsy of the mass. And the mass showed round cells which were positive for MPO, and CD68, CD34 were also positive, indicative of myeloid leukemia. So negative peripheral blood smear is also possible in these cases, and it does not rule out myeloid sarcoma. So the child can have alloleukemic leukemia or can be on steroids. So many a times we give a steroid washout time and relook into the peripheral blood smear in these cases. So a 5-year-old boy, the child was being treated as a case of orbital cellulitis with IV antibiotics, but you can clearly see that the other eye also has a white reflex there. So the child has also undergone CT scan, and the CT scan clearly showed intraocular tumor with calcification when the child was referred to us. But a word of caution here, for this child, CT scan is not the preferred modality of imaging because it's a case of bilateral retinoblastoma. So they are at increased risk of pinealoblastoma with radiation exposure. So MRI should have been done in this case. So it's bowtie retinoblastoma. This is just whenever there is a necrosis of the intraocular tumor, there can be such orbital cellulitis-like picture. So IV steroid, IV antibiotics are not required. With IV steroid, the swelling came down and then the patient was treated as per the grouping. So orbital and ocular imaging is a mandate whenever fundus is not visible in the clinic. Moving on to the sixth case, a 2-year-old female. What do we see here? We see left eye prominence, but what we also see is this periocular ecchymosis, which is more prominent in the right eye. So again, a history of 3 weeks. What we see is raccoon eyes. So and now going ahead with an orbital imaging, it is osteolytic lesion, a typical triradiate lesion. It is causing osteolysis. There's an orbital component, a middle cranial fossa component, and a temporal fossa component. So on systemic evaluation, the child had abdominal distension and pedal edema. We went ahead and just did an ultrasound abdomen and could see a mass in the suprarenal region. So this is a case of metastatic adrenal neuroblastoma. So this is the classical triad, what we call as Hutchison's triad: periocular ecchymosis, proptosis, and bony facial swelling in children less than 10 years. Suspect metastatic neuroblastoma. Again, this 8-year-old boy came with prominence with vision loss since 1 week of the right eye, and there was a CRAO like picture in the right eye. You can see the mass causing indentation. So we went ahead, we did a peripheral blood smear, again was negative. We went ahead and did a incision biopsy, and on incision biopsy we could see this blood vessel with plump endothelial cells. So this was a case of angiolymphoid hyperplasia of orbit, CD31 positive. So these cases, this is a benign condition, and they respond very well to oral steroids. So ALHE is a very rare but benign idiopathic vasoproliferative disorder responding well to steroids. So again, a 3-year-old female, the child was diagnosed elsewhere as optic nerve glioma, rightly, as you can see the cafe-olate spot on the body, and has also received chemotherapy 6 cycles with external beam radiotherapy. However, the child was referred to us after 6 months when as a case of non-resolving optic nerve glioma. So this was the clinical picture at this point of time. And you can see that it's a homogeneous optic nerve mass with a chiasmal extension which is spreading through the optic canal. So a typical picture of optic nerve glioma. But what we need to remember here is that the progression, whether it is progressing or not, it is not judged by the orbital imaging feature, because we don't expect a complete shrinkage of the mass with chemotherapy or radiotherapy. These cases needs to be assessed based on clinical factors, like we need to look into the vision, the visual fields on a regular basis to understand progression. So if it remains same status quo, that is also fine, provided there is no clinical deterioration. So the combination of clinical deterioration and radiological progression guides us in treatment of optic nerve glioma. So a 5-year-old boy, left eye, again rapidly progressive proptosis. We can see this superomedial mass. Excision biopsy revealed the diagnosis of orbital rhabdomyosarcoma. So this is for whenever it is a rhabdomyosarcoma, whenever we suspect a rhabdomyosarcoma, we should do as much as debulking as possible and not do just an incision biopsy, because this is we treat rhabdomyosarcoma based on the IRSG grouping system, and the prognosis differs if just an incision biopsy is done. So for the multimodal therapy, we need to do a debulking. So avoid incision biopsy and perform complete excision in cases of orbital rhabdomyosarcoma. The last case, 3-year-old boy, right eye prominence since 1 month. And this is what we see on a CT scan. It is an osteolytic lesion in the superior orbit with a soft tissue density, very typical of a Langerhans cell histiocytosis. So this typical clinical picture, we can right away while taking the incision biopsy, we can inject intralesional steroids, and they do great with steroids. So superior orbital mass with bone destruction in a child. Think of Langerhans cell histiocytosis. You can confirm with frozen section if you have it available, and inject intralesional steroids in the same sitting. Systemic workup is mandated to rule out multifocal involvement in these cases. Thus, to summarize, all pediatric proptosis is not orbital cellulitis. We need to be beware of pseudoproptosis, sudden intraorbital hemorrhage in a child. Think of venolymphatic malformation and consider bleomycin sclerotherapy. Rapid onset proptosis with subconjunctival hemorrhage with bilateral soft tissue homogeneous lesion. Just do a peripheral blood smear and rule out myeloid sarcoma. If PBS is negative, still then we need to go ahead and do an incision biopsy. Orbital imaging is a mandate whenever we can't see the fundus in the clinic. Periocular ecchymosis, proptosis, bony facial swelling in less than 10 years, always keep neuroblastoma as one of the topmost differentials. ALH is a rare benign idiopathic vasoproliferative disorder which respond well to steroids. Combination of clinical deterioration with radiological progression guides treatment in optic nerve glioma. Avoid incision biopsy and perform complete excision in cases of orbital rhabdomyosarcoma. Superior orbital mass with bone destruction in a child. Think of Langerhans cell histiocytosis. Confirm with frozen section and inject intralesional steroids. Thank you, everyone, for a patient listening.
Thank you so much, Dr. Ansuya, for those pearls in diagnosing pediatric proptosis so that we don't miss the important point there. Since we've come to the end of the first session, we can have a short panel discussion because we have all oculoplasty people in our panel. We have Dr. Sujata Madam, Dr. Kasturi Bhattacharya, and Dr. Ansuya is here. And I don't know if Dr. Madhu Madam is there. She also does a lot of oculoplasty. So any question to the panelists or any points you would like to highlight, Sujata Madam?
Very nice talks, both of them they're given. I really enjoyed, learned a lot, even from their talks. And especially Ansua's talk, lot of things, a lot of pearls I learned, especially when she said avoiding the CT scan in case of retinoblastomas, because in view of trilateral retinoblastoma involving the pineal gland involvement after the radiation exposure is one of the important pearl. It's straight away they can go for the MRI instead of CT scan. That's what I learned today. Very good point. Thank you, Ansua, for this point. Thank you. Anything more you want to speak about this point?
Yeah, thank you, Sujata. So I was like the first talk by Dr. Madhu, I was like we could all, I am sure all of us could relate to it a lot. So one more point regarding that talk, if I can just say, Madhavi.
Yes, please. Yes, please.
Yeah, so while we absolutely agree to all the challenges Madam enumerated in the talk, and we relate to them, but I think if, we all know that for being a great leader, it is not only about your IQ, it is also about your emotional quotient and your spiritual quotient. And we females are extremely fortunate, just by the virtue of being a female, being a mother, we are all fortunate to have more emotional intelligence compared to our male counterparts. And there is enough evidence for that. And I think that is one of our power which helps us in the leadership role.
That's right. Actually, I would like to add here that women are really great in multitasking. We can do it all with Ilan. You know, but we take it also personally. So even a little bit of underperformance in any sector, we are not happy. We would like to do the best at home, at work, with our friends, everything. Like, you know, so we can do a lot of multitasking, and that's really, we are blessed with it, actually, to be very frank. I have seen that we multitask better than the men, with due apologies. So I think, shall we move on with our program? So next we are coming to the second session. And here we have the keynote address by none other than Dr. Subhadra Jalali, Madam. She is an international figure, but to talk a little about Dr. Subhadra Jalali, ma'am, she is the Network Director, Quality Director at New Eye Health Alliance consultant ophthalmologist. She is a vitreoretinal, yes, you can see it all there. She's telling what she is. She has always been very, very inspiring to all of us, right from I finished my PG days. Since then, we have been following not only her talks, the way she enjoys with all of us, the way she enjoys in all conferences. She motivates us to dance as well, sing, dance, everything. So we are so happy to have you here, ma'am. And her talk is take care of them till, look after them till they fly. So that's what ma'am is going to tell us all about. Over to you, ma'am.
Thank you. It's lovely to have all of you here. And I think that I'm just taking on to what Ansua said, that we all can multitask. And these are all the multitasks we did day in and day out. In addition to being the, the doctor that you know me, we have so many other valuable roles in our life. And obviously, we don't want to give any of that away. And, it extends from our personality, our work, to being the cultural ambassador, ambassador of values, ambassador of a nation builder. And this all gets ingrained into us because of the EQ that we have, in addition to the best IQ that we have. So today I'm going to just speak about, the dilemma that many people have about how they go about living their life when they are high-performing career-oriented women. And the topic I have chosen is to bringing up our kids till they fly away. And both these lines are important, to bring up our kids and then let them fly away. So all of you know me as this lady who works, but I want to share from the story of my birth, which gave me a lot of confidence, because my father danced and arranged a huge feast when I was born, just because his sister said, "Oh, why are you dancing? Only a girl is born." So in our Kashmiri Pandit families, usually the girl child is highly valued, unlike many other, people. But in spite of that, some bias is there for the male child. And so when my father danced at my birth and he didn't dance when his first son was born, and the family said, "Oh, it's only a girl, why are you dancing?" And he had no money, but he borrowed and he arranged a huge feast. And in my childhood, all my cousins, we lived in a joint family, 20 of them, would always say that, "Don't touch her, she's very special," because her father had a feast, which none of us had when we were born. So this gave me huge confidence, and that you see reflected even, 65 years later, that I can do anything. I am the most important person in this world, and I'm privileged, and I can, make things happen because things happened when I came to this world. My sister, who was born after 2 years, I am told that the day she was born, it was a home delivery. I entered the room and grabbed the baby and put her against my nipples and said, "Only I'm going to feed this baby, only I'm going to change the diapers, nobody else is going to touch this child." So maybe being a doctor and nursing and caring was there inborn right from the time that, my sister was born. My training remained a lot of, home-based values. My grandparents, my parents, they were into a lot of Hindi Sahitya, Hindi literature, spiritual training. So that went on side by side, my education in a convent school. So there was a lot of exposure to diversity, to multiple things. And then I was introduced to Tagore when I was 7 years old in school. And this poem, where the mind is without fear and the head is held high, into that kingdom of heaven, let my countrymen awake. This used to bother me because I used to laugh and say, why did Tagore say, where the mind is without fear? I mean, fear is in the heart. हम तो दिल से डरते हैं, दिमाग से थोड़ा ना डरते हैं. But over the years, I realized that he was right. The fear is in our mind. We are so fearful of doing something different. We are so conditioned to do the same thing again and again that, we don't move out of that comfort zone, or we are scared. But as I said that I was a maverick, I always took things head on. I always wanted to explore. I had no fear, either in my mind or in my heart. And I was always this person who was questioning dogma, questioning things, whether it was in school or college or home. And then continuing my school, college, home, I used to have a lot of diverse experiences and exposure. I also was very fortunate to be a voracious reader, and I think all of us should encourage our children to read right from beginning when they are rowdy or they're not listening to us. Give them a book. Don't give them a chocolate. Don't give them a cell phone. Don't give them a mobile. Give them a lovely, nice book which they can handle, they can touch, they can read, they can feel it, and let them be voracious book readers. It doesn't matter what's the book about. I used to read a lot of books, fictions, biographies, all the banned books I used to read as a child, all the sexual things I used to read as a child, but non-fiction, which I think is very, very important to develop our personalities, was brought to me once I got engaged at about 19 years of age. And now I read more of non-fiction than fiction. So I think both the things, there's an age, there's a gradual, change in what you like to read. But I think reading is something which we should inculcate in everybody. Now my children, of course, they read a lot. My husband reads a lot. I'm very, very lucky. My parents are now 85. Even today, if you go at 11 o'clock to the bedroom, both of them are with books and reading. So this is something I think is going down, but we should encourage. And of course, then when I had my two kids, I learned a lot of things from them, and this widened the horizon. But this is where we met, me and Subhash, in Pahalgam, where you're seeing the Amarnath Yatra nowadays. And we were engaged and then got married after 4 years. But this was very important, although I was very young and had no idea why I'm going to get married. He asked me, why do you want to get married? I said, because daddy ne bola. So daddy ne bola, ladka dekh ke aao. So I said, fine, there's no issues. I can go and see the boy. I'll come and say no. But, he was so impressive because I told him at that time that, I'm happy to live the way you want me to live. I'm happy to go out in a bikini with you on the road. I'm happy to be in a ghungat for you. Whatever you like, it doesn't matter. I am happy to live the life that you want me to be. But don't ever hit me. If you hit me, I will hit you back. Very hard, strong, and I'm not that Pativata Nari. So, he was a nice guy. He took it lightly and he was like, no, don't worry, I'm not going to beat you. And, but I had heard, I had seen even people from good families, the wives being beaten. So, that was something I was very sure that I'm not going to take it. And my father never used to let me travel anywhere, even to a birthday party was not allowed. And he would always say that, you will travel once you got married, and after you marry, then you can go wherever you want. So I did speak this out to this guy that, do you have any objection to my travel? He didn't realize all the travel that I'll be doing. He was innocent. He said no. And now he's being taken for a ride. He knows I'm traveling all the time. And then, of course, as I said, that I didn't want any dogmas or superstitions. But this is what picture I wanted to share with all of you. This is the picture where, the family, the women of the family are dressing me up for my bridal thing. And they're tying this safa, which was given to us by Shankaracharya for our wisdom. And the songs they are singing is saying, you're getting married and it's your duty and your responsibility to gain knowledge and gain wisdom. And this is what is told. You're not told like, have children or look after your parents and things like that. They're just told that it's your duty to gain knowledge, gain wisdom, and follow the truth. But if you see this picture, there's a lady behind in a white dress, and she's one of the saints very well known in the valley of Kashmir. At 5 years of age, she negotiated with her family and said that, at 5 years, she said, I want to be a saint. I want to do prayer. I want to do meditation. I want to stay in a jungle, in a hut far away from the city. And she was allowed that. And same way, if you see all these women, who are here, I always see, they were very powerful women. So nowadays, we women say, work-life balance, a lot of hard work. Hey, come on, these women had so much of, conflict and so much hard work-life balance for them. They used to look after big families, 50, 60 people, cooking the whole day, getting up 5 in the morning, doing the masala, doing the, servants, the houses in Kashmir are mud houses, so they had to do the mud cleaning of the houses from top to bottom. They had to carry all the food which was cooked in the ground floor up to the 5th floor where the dining table used to be there and the whole family would sit. So, and then they had hardly any time with their husbands, children. All the children used to be looked after by the whole family. So they were really hardworking, but they had their own space, and they would negotiate their own spaces. So, that they would take very responsibility. So we should not look down upon them. We should, learn from our family members, how they negotiated, how they went through different crises of life and still, smiled and went ahead. This is one of the rules I made, that this is the time I just entered my in-laws' house, and on the wall I wrote big, mother-in-law is always right. I indulge her, I pamper her, I just take care of everything she wants, and she has been looking after me and my house and my kids all life. And there's been not a single word between her and me. So I always made the rule that she's always right. Whatever she says in the house, I'm the queen in the hospital. Everybody has to follow what I say. I negotiate in the hospital. I have a team in the hospital. But once I come home, she's my leader, and I indulge her. And that's been a beautiful relationship between her and me. My PG, I went to PG. There you can see me, nice tiny girl in this whole department. And we had a well-planned pregnancy in the second year of PG. We planned for that baby and we had it. I request everybody that please have your family alongside your career. Don't postpone it for later. Postponing for later creates a lot of problems. Don't think that the child is going to hamper your career. They grow along with you. You are young. You have a lot of family support. You may have a crash or whatever. Negotiate your team. I will show some of that there, but don't keep on postponing. And then, then you become an elderly primary and you become elderly mother, and there's a lot of generation gap between you and the child. So have your children along with, your life. Don't postpone that. Don't keep balancing between one and two. Weave it into your whole life. That's what I wanted to say, that when he was 18 years old, I handed over to my mother-in-law, who I know has brought up the best person in my life, my husband, and I knew that she's going to put care. And together we took care of the child while I was studying, and she was in a different city. She would get him there every alternate month, and I would go home every alternate month, and we raised the child together. There was no issue. And then, the life changed. The life changed because there was a fire in my state. The whole state was in turmoil. People were killed. Our house, this is my house, ancestral house, 5-floor story, where 100 people of the family used to stay in my husband's family's house. It was ravaged, and we landed up in Hyderabad. He came to Hyderabad with no money, no language, no godfathers, but we had the language of love. Very studious, very hardworking. We met lovely people of many communities here. And we had to postpone our second child because, we had nothing on the streets. So the terrorism in Kashmir engulfed our life in 1991, but it didn't engulf our spirits. We still made these lovely trips with our kid. The kid came to stay with us permanently now after 4 years. We went all over the place. We found solace away from home. And then we had our next child. And the next child was a preterm baby. It was a very traumatic pregnancy and post-care. But, everything was going on together. So people look at me and say okay, I'm dancing, I'm happy. I do that because I know that life is full of tragedies and we should not let tragedies overcome us. They will take their own route and they will end. So I had severe head injury when I was 4 years old. I have a big dump on my head if you touch my skull. And there were no neurosurgeons at that time. And the treatment for head injury and paraplegia was to keep in a dark room for 6 to 8 months without lights, without sound, so that you don't get fits. And my mother thought I'll never walk again. But here you can see me running and dancing. So I'm just saying that tragedies will come. Just handle them. They will go away. And my favorite uncle who introduced me to Tagore, he died on a scooter within a year of his marriage, and subsequently 2 of my nephews have also died. So I'm very sensitive about safety. Maybe that's why I'm the quality in charge here. From that childhood, I'm very conscious about safety and about helmets, seat belts, locking, looking at grills, handrails, anything to do with safety is just ingrained in my mind, because I saw that he died just because he was in the campus and didn't wear a helmet. Both my parents have been treated for cancer. I've been, by them, they're now 80 plus. They are cancer survivors. My mother-in-law is now having Alzheimer's. We are taking care of her in various ways. My husband's close family member had acute onset permanent hearing loss, and one member was severely disabled due to galactosemia and died at 16 years like a vegetable. He was kept in an empty room for many years. I have handled that boy. And one of his cousins also had schizophrenia. His family lost all the gold stolen from their bedroom. This was a huge, setback to the whole family. And as I said, we lost our home. And then more recently, I had a preterm baby who did not cry at birth. He had birth hypoxia, but he somehow had a very genius memory. He was unsocial, and I was told that he will never study and he'll be autistic. And just see, he's just completed his IMM from Ahmedabad, IMA. So there are some non-negotiables in my life which I have stuck to, that the school should be next to the house. I don't want my kids to go to
Ma'am? I think we are not hearing. Dr. Subhadra, ma'am?
Your frame is frozen, I think.
Yeah, that's what. I think ma'am will have to log out and log in maybe. That was such a emotional and inspiring talk. I wanted to hear till the end. Is she back? I remember ma'am had given this talk sometime for us in WAS, and I had liked it then. I really enjoyed it today once again. It's really so good. Because all of us do have that. So many setbacks, but to rise above those setbacks is something inspiring. I think ma'am has lost connection because I don't see her there.
Yeah, and she's not even picking up her call. So
Yeah. I tried messaging also, but okay, I think we'll see if she logs in back. Till then, we can. This second session is on retina. So one talk by ma'am, inspiring one as to how to take care of our kids and our lives as well. So we'll go on to the next two talks, one by Dr. Chaitra and the other one by Dr. Neha. So these are about the two complications or not complications exactly, problems we would see post-operatively. As cataract surgeons, we really don't like these two complications. We almost dread them. So to talk about the first one, we have Dr. Chaitra Jaydev. Dr. Chaitra Jaydev is very well known to all of us, but talking a little bit about her, she is the director, she's a head of vitreoretinal services at Narayan Netralaya. She's done PhD from Maastricht University in Netherlands. She's the healthcare leadership program. She has a degree in that from Harvard Medical School. She's also done her PGD MLE, that is from the National Law School, Bangalore. She has more than 160 publications to her credit. She's a joint secretary at VRSI and the scientific chair for Karnataka Ophthalmic Society. So, Dr. Chaitra, we are so happy to have you with us. Can you please share your talk?
Yeah, thank you so much for having me and for the opportunity. I hope my slides are seen.
Yes, we can see your presentation. You're audible.
Yeah. So today I'll be speaking briefly on the recent advances in pseudophakic CME. I think we've all been treating this particular condition for several years, but a quick recap on what it is, why it occurs, and what are the new treatment options that we have for the same. Before we actually go into it, is the problem as big as we make it out to be? Well, it is. Overall, the incidence in Indian patients, especially, you can see clinically in about 2% of patients, even in uncomplicated cataract surgery. But when you look at it at an angiographic level, it's seen close to 20% of these patients. Not all of these patients would, of course, require treatment. Some of them will resolve on their own. So the incidence, if you look at in Indian patients with diabetes, then obviously it becomes very important because we see a large number of cataract patients also being diabetic. Here you can see it in close to 47% of patients without pre-existing diabetic retinopathy, and close to half of them can develop pseudophakic CME when they have pre-existing diabetic retinopathy, which is why we need to keep them on a close follow-up. So we look at the development, the classification, risk factors, diagnosis, and treatment here. So we know that it occurs due to inflammation, which occurs secondary to the surgical manipulation that we do. There is disruption of the blood-retinal barrier, leakage from the perifoveal retinal capillaries, and finally accumulation of the fluid within the intracellular spaces of the retina. That's why you start seeing the cystoid spaces. Now, this is the feedback loop as to how it occurs. It's an interesting diagram that shows you the different anatomical layers where it can affect. And finally, the ultimate thing is that there is breakdown of the blood-retinal barrier and cystoid macular edema. So as per the onset, you can have either acute, late, or chronic, which lasts over 6 months. And the risk factors, like we already mentioned before, is primarily due to the surgical manipulations or the complications that occur. Either it could be trauma to the iris, a PCR, an intraocular lens dislocation, vitreous loss, and especially when you haven't taken good care of it, you can see post-op CME, which can last several months. Incarcerated vitreous, like I said, we need to take good care of it and ensure that there is no remaining vitreous there. Cortical remnants in the vitreous can cause constant inflammation. Iris fixated or anterior chamber IOLs also, when it is not very well done, you can still have inflammation and CME. So even though it is seen after an uneventful cataract surgery, the incidence is, much more in complicated cataract surgeries. And because now cataract surgeons are doing such a good job, the surgery is quite well done, that we don't see that many complications anymore. What about pre-existing ocular conditions? Yes, like I already showed you in the statistics, diabetes mellitus or pre-existing diabetic retinopathy, a history of RVO, epiretinal membranes, neovascular AMD, RP, any of these can increase the risk, and preoperative or perioperative use of prostaglandin analogs itself. So that's why this history taking is very, very important, because most of them will not even know that they're using PGAs, and unless you ask for a history or ask them to show their medication list, they may not tell. And of course, an untreated elevated IOP is also a known pre-existing ocular condition. So how can you diagnose? It's either clinical, OCT, Opta, angiography. Clinically, you can see the cystoid spaces sometimes very clear on your slit lamp biomicroscopy. And then, of course, the OCT is a very objective way of not only diagnosing, but also monitoring response to treatment and follow-up as well. This is a multicolor image. You can see here how beautifully you can see the cystoid spaces. Likewise, when you do your 78D or 90D, these spaces can also be seen and you can diagnose it clinically. You don't always need an OCT or an angiography. Like I said, the OCTs are only required for monitoring response to treatment. And then you have the angiography, the typical pattern that we see on FA. Opta has now recently been started using, you can see the on-fast also, you can see the maps where it shows the thickening. This is not mandatory, but just a nice research tool to see what are the changes at the different layers that we can segment on Opta. Treatment is simple. First is topical, then sometimes even oral medications. Injections when it's very severe. Some have used laser, but with the success of injections, we don't use it much. And then surgery if there is a persistent traction. So this is the chart that is quite helpful as far as NSAIDs and topicals and other medications go. So this has a comprehensive list of all the medications that can be used for pseudophakic CME. Coming to the topicals, you have NSAIDs or interferon. What they do is they rapidly permeate through the cornea and the sclera, and they block the inflammatory mediated breakdown and therefore help. This is definitely useful as a prophylactic medication, and sometimes if there's very less or minimal CME, it can also help. So administered prior to the surgery, continued for at least 2 months post-surgery, helps in reducing the risk of development. Like I said, it's good for prophylaxis. Now coming to interferon, these recent studies have concluded that topical interferon can be an effective choice for the treatment of pseudophakic CME, and we have done a study too at our center. Mean duration of complete resolution was around 5 weeks, and it can be an effective medication for resolution in this subset of patients who have had a PCR. So these are some of our other publications from the center where we are able to show how it helps in the management of pseudophakic CME. This has also been used in uveitic macular edema with good results. So it's basically it's a medication that you'll have to buy and then make it into topicals for your patient. Then coming to oral carbonic anhydrase inhibitors, this has definitely been used. We see complete resolution. When they have done, one study has shown complete resolution in about 90% of cases when they've used a combination of acetazolamide, NSAIDs, and steroids. Steroids, implantable steroid devices are effective. We've been using periocular and vitreal steroids forever to manage CME. Compliance is better, but the biggest risk factor is the raise in IOP. But because of the sustained and the longer duration of action and good response, the patients definitely prefer this rather than taking medications on a daily basis. So you have periocular steroids, which is subtenon, suprachoroidal, and then you have intravitreal, which can either be a DEX implant or IVT. Now, anti-VEGF, this one particular study that showed that nearly 30% of them required a second injection and about 15 required even more. There is lesser risk of IOP in these patients. So maybe it is definitely helpful. We do use anti-VEGF. The only thing is we know that steroids have a slightly higher anti-inflammatory action than anti-VEGF. Laser, subthreshold micropulse laser has been used. Here there is repetitive short pulse in subthreshold mode. There's no damage compared to the conventional laser treatments. And then you also use 577 nanometer here, and you can use different grids with confluent spots and 5% duty cycle. Here you do see complete resolution of the retinal edema and improvement with no side effects, but access to this laser is not available at all centers. So we may need to only use it in patients who have it at centers with this particular laser mode. Now, coming to surgery, like I said, you only need it when there is a lot of, vitreous adhesions, or there is persistent vitreous traction at the macula. So it could be the cataract wound. You can do a YAG vitreolysis here, iris, lens implant, and then you release VMT. Of course, you will need to do a vitrectomy with the membrane peeling. And sometimes you'll need to do the vitrectomy to remove the retained lens particles to reduce the inflammatory load. We did a quick study on biomarkers, and so this is the same eye, same patient, both eyes, and you can see post-treatment, one eye has resolved very well. In fact, the other eye has worsened. So this is how it got us to think that maybe the local biomarker load is different in each eye of the same patient. Forget different patients. So we wanted to look at the different mediators and inflammation and what causes increased vascular permeability. And we wanted to evaluate the role of these inflammatory biomarkers in the pathogenesis of macular edema. We collected aqueous from patients undergoing intravitreal injections and those undergoing surgeries as well. We used the CBA or the cytometric bead array on a flow cytometer to see the different molecules, biomarkers in these samples. So this is how we do it in our lab. We collect it and send the samples where they process it further and run it on a flow cytometer to get the readouts. So this is how we get the readouts once we send it through the entire process. And what we saw was cytokines such as ICAM, VCAM1, IL-6, 8, and MCP1 were increased in the persistent macular edema group, which could indicate progression of the disease or resistance to anti-VEGF treatment, because you see inflammatory biomarkers are much more. So this study basically showed us the non-VEGF mediated pathway that could be targeted for therapy. We are now in the process of making this biomarker kit as well, where we can use just a tear sample or a plasma sample in the OPD itself and run samples. Since we do a batch processing, we get multiple readouts for several patients at the same time. So this is how the sample collection, the storage, and the analysis is done, very similar to what I showed you, and then you get a readout. This way, I've done it in those patients with diabetic retinopathy using aqueous humor. So this is one last case, a 76-year-old gentleman lasered stable PDR with CME in the right eye. You can see 618 vision. Patient received anti-VEGF. Yes, you do see some resolution, but it's not complete, and there was persisting CME. So when we subjected the aqueous that was taken at this time, what we saw that the inflammatory markers were much more than the VEGF markers. So IVTA was given, and then we saw complete resolution. So like I said, this study basically sheds the non-VEGF mediated pathway for inflammatory, stressors for causing macular edema. So to conclude, pseudophakic CME is more common than previously appreciated or rather underreported. Advances in OCT and OCT angiography technology does allow non-invasive detection, quantification, and monitoring. And high-risk populations should be screened ahead of the development of vision loss, and we have to preempt it and treat them before they even complain of any visual acuity deficits. And prophylactic treatment for CME, yes, improvement in cataract surgery techniques, I think we're already there. Care to prevent vitreous human loss, that primarily depends on the complications you encounter intraoperatively and the skill, but I think most are doing extremely well. Perioperative NSAIDs, we discussed. Avoidance of the use of topical PGAs in patients with high risk for CME. That will help when you screen them preoperatively also. There's a significant need, of course, for topical IOP lowering therapies that do not have a risk of worsening CME. And of course, customized treatment options based on maybe once we start using the biomarker kit in our OPDs. So when you refer to retina, most can manage to treat patients at their center itself. But when you don't see good response or you're seeing worsening as soon as you start lowering or tapering the topical medications, I think that would be the time to refer to a retina specialist for intravitreal treatment. I'd like to acknowledge my clinical and my research team and all our patients for this particular study that we've done. Thank you so much.
Thank you so much, Dr. Chaitra. It was a very nice talk. It's a complication we all, actually don't like to have, especially when it's an uneventful cataract surgery. But then, nevertheless, we do face it. So here I have a question for you, Chaitra. You are doing some biomarkers, right?
Yes.
Is the inflammatory type of biomarker and the load different for a diabetic macular edema and post-cataract CME?
Yes, so the initial pilot that we did was in diabetic patients. So we've not really, now that we've collected a large amount of data in almost all the patients that we're injecting, we will be publishing that subset of pseudophakic CME. This was a representation that I did for patients who had non-resolving diabetic macular edema.
Okay, so you had to come to any conclusion regarding... Okay.
For the pseudophakic CME biomarker load, we will be coming out with the results soon.
And in the diabetic also, did you, for the type of the biomarker that is there, is the treatment option different? For a particular biomarker, it's a steroid, and for something else, it's an anti-VEGF or something like that?
Yes. So currently what we are doing is based on our clinical, acumen and our OCT biomarkers, we do decide whether it is a steroid or an anti-VEGF. But once we're able to analyze some subset of these patients, I think we did one of these studies when Dr. Neha was there as well. What we did is based on these biomarkers and non-response to treatment, we actually changed the medication that we're using. I have some more patient examples, but it will be too long to show that. We saw that somebody who was not responding to anti-VEGF post-steroid had complete resolution. So yes, it is going to help us individualize treatment the minute that, you can actually assess it in the OPD. Currently, what we have to do is send it to our labs, and that will take time for processing because, like I said, it's economical to do a batch processing. You can't do an individual dipstick test, okay, the OPD and decide, okay, this or that. But I'm sure a time is going to come when we're going to be able to individualize our treatment.
Yeah, we need to look into all the logistics. That's right. Yeah. Thank you so much, Chaitra.
Thank you, Dr. Madhavi.
Yeah. I think we were listening to the last concluding remark of the closing slide of Dr. Subhadra ma'am. We lost her. Back to you, ma'am. We are waiting to listen to you.
Yeah, so I just wanted to conclude by saying that whatever is most important and which only you can do, you should do. For other things, just like at your workplace, build your teams and outsource and have the other people do that. The most important work, which I think as a mother we need to do, is to build the character, the courage, the strength of our children so that they can face anything in life, even if we are not there. We should not pamper them and be on their side. And then once we build them, let them fly away. I've seen so many mothers, they become so panicky when the children say that they're going to go away or the child goes away, and then they think like, Hamara budhape mein kya hoga? What will happen to us in old age? No, arrange your old age. Arrange the money for your old age, arrange your help, be friendly with your neighbors, see who's going to help you. Don't put the burden of your love on your child for them to repay it back to you by being there. If they're there, that's fine. It's a bonus. But if they're not there, don't be, clinging to them and making them, sort of be responsible for taking care of you. We should take care of ourselves, our health, our mental health, and we should be strong enough to live our life alone. Have our own hobbies, have our own lifestyle. Let them fly away. The birds, they take care so much of their children, build their nest, drop by drop, they'll feed the bird, and then that bird will fly away. And that bird will make a very good nest again. So don't worry about them all the time. And yeah, you are there as a support to them lifelong. Of course, they are part of your DNA. Ensure that they have full confidence in you and they reply to you and they are in contact with you, but don't tie them to yourself. Be free of all strings, whether it's your husband, your family, your kids. You are an individual. I think that is the way the spirituality takes care, and then you can be great. And today, when I am 64, I am in my Vanprastha ashram, and as per our scripture, Vanprastha ashram is the time to give back to society. You've done your, Grahastha ashram very well, and now you should be in complete bliss to give back to society. And then, of course, we'll go into the next phase of sannyas.
Thank you
I just
so
want to
much.
make one comment on what Madam says. I mean, we're all obviously inspired so much by what all she's done. And every time we get a little bit more push to go do it in the way that she has done it. But I think at one point we want to do everything by ourselves. This is especially related to work. And then as you get older and more senior, you have to be able to delegate things to others, because you cannot do everything to the best of your capacity. You want to keep all the cards close to you because you want probably the glory. I mean, I'm just putting it very frankly. But then when you realize that the overall development of the institute or the specialty is much more when you give each person their own strengths to develop and grow. I think that's something that is a major take from
the
Madam's
more
talk.
your team grows, it's like your children, you bask in the glory of your children, you bask in the glory of your students and your team members. The more they do well, your glory increases, it doesn't decrease. Don't feel unsure or nervous about your students or juniors or colleagues going ahead of you. That's the glory if you empower them.
And nothing is permanent. We have to hand over things. We have to, let us do it in the right way so that the next Gen Next is going to do it better than what we did.
Yes.
Thank you so much for this pearls of wisdom, ma'am. Really.
And I'm only a phone call away. I'm only a WhatsApp away. I'm only an email away. Anytime anybody has any queries, please reach out.
Thank you. That's really nice. Thank you so much. So let us move on to our next talk in the retina section. That is how to approach to a case of endophthalmitis, another complication we all are really scared of. To talk on this, we have Dr. P. Neha Sudhakar. She has done her vitreoretina from Narayan Netralaya, so she must be mentored by Dr. Chaitra herself. She has, to her credit, presented papers and she has won a few awards as well. She has a lot of publications. Currently, she's working as a vitreoretinal consultant at Sushila Netralaya at Kurnool. Over to you, Neha. Neha, are you there? We can see your slide, but can't hear you.
She needs to unmute. Neha, unmute yourself. You're still muted.
Ma'am, can you hear me now?
Yeah, now we can hear you.
Okay. Sorry about it. So thank you, APOS, for giving me this opportunity. I feel very happy that I'm able to present in front of my teachers. I have Dr. Barney Kumar sir, under whom I've done my post-graduation. Then I have Dr. Chaitra ma'am, under whom I've done my vitreoretinal fellowship. And I'm under Dr. Subhadra ma'am, where I've done my ROP screening and ROP lasers, where I'm able to do all ROP work in Kurnool alone, do screening and lasers now. So I thank you all for giving me this opportunity. So to start with, endophthalmitis, for a cataract surgeon who has so many things, like a private practitioner who has things like looking into finances, medical legal issues, patients, managing hospital, another thing which adds up is endophthalmitis. It's a very dreaded complication, but don't worry, if you are a very good cataract surgeon, it is going to happen at some point of time in your career. It is not a never event. But it also doesn't mean that it is because of the substandard care you're giving. Don't worry, we are there as a VR surgeon to help you with it. So if you take any disease per se, we have various levels of prevention according to it, like primary, secondary, and tertiary. So we look into the preventions, how we could do for endophthalmitis also. To start with primary prevention, preoperative measures, look for any infections, be it in the lid or lacrimal apparatus or your conjunctiva cornea. Please make sure, and retina, make sure there's no signs of infection. Check Croplas or syringing day before surgery or before, but not on the day of surgery. Also, no contact procedures on the day of surgery, like tonometry or A-scan. Then you can also use topical povidone. There are a lot of studies which have shown that it is quite efficacious in preventing post-op endophthalmitis if you use it prior to surgery.
So you have to apply it in a correct way and at correct percentage. So when you're using it over periocular skin, it could be 10% of povidone iodine, which has to be there for at least 3 minutes. You can't wipe it away immediately. And then if you're applying drops, it's 5% of drops in the conjunctival sac and has to stay within the eye at least for 1 minute. But be aware there are certain anaphylactic reactions which can happen to people who are allergic to iodine. What is important is in povidone iodine, you have to look for the concentration. The lesser the concentration, you have more of free iodine which is present. That means it acts faster because you have more free iodine, and the only disadvantage is it will act for shorter duration of time. Then you have topical antibiotics. Theoretical goal is it will reduce the conjunctival bacterial load, thereby lowering the risk of contamination. But theoretical risk is the patient can develop antibiotic resistance. That means the antibiotic might not work when it is required. So you can choose your patients. So there's no strong evidence that topical antibiotics prior to surgery is efficacious. But you can choose your patients like an immunodeficiency state, diabetes, terminal liver or kidney diseases. You can give them antibiotics prior to surgery. So there's also many studies which have shown that intracameral usage of antibiotics have been done. So there is cefuroxime and moxifloxacin, which are being widely used. Cefuroxime mostly in foreign countries like Europe. Moxifloxacin, which we use because it's easily available and cost effective for us. So there's no significant difference in action-wise among both of them, but this will actually reduce there's a study which has shown that it has reduced the coagulase negative staphylococci endophthalmitis significantly. So there's another study done by LVPI where they have added amikacin to the BSS solution in areas where they have seen a lot of nocardia endophthalmitis, and there's a significant decrease in it. So there's another way of using the antibiotics. So eyelash clipping, nowadays none of us are doing this. It is not mandatory, just that place the drape properly such that the lid margins are covered very well and lashes are away from the operating area. Then diabetes, as we said, diabetes is a culprit for every disease in retina, I can say. So you have to look into fasting blood sugar and postprandial. You have to be very particular about these readings, and diabetic patients are at risk of developing endophthalmitis as compared to a non-diabetic because of poor wound healing in them. So you have to make sure that the wound healing and the wound sealing are done very well. Apart from these, I wanted to also add few things on how you maintain your OT, because this is what we lag when we actually do our fellowship, or we don't look into these details. So this is very important. You should always know as a private practitioner that you should have 3 zones in your OT layout: a sterile, semi-sterile, and a dirty corridor. And there should not be any crisscross of your instruments from dirty area to a sterile area. So all unsterile instruments have to go from the dirty corridor to the CSSD, and the sterile things have to directly come to the OT. You cannot cross over them. And these are also other few things which you have to check in your OT to make sure that your OT is sterile. So you have to look at air particulate count, air change rate, air velocity, pressure differences. If you have a laminar OT, look for the HEPA filters. Then you should also look into cleaning protocols, how the walls are washed with what, how is the floor cleaned, how many times, when is the roof cleaned. And you should also know the newer techniques now which have come, the 3-bucket technique, like how to clean the things, whether we can use a dry mop or a wet mop. So these are all very particular and very important. And you should also be very particular about doing the microbiological testing every month. It is also important to look into finer details like number of persons who are there inside the OT when you're operating, number of times the OT door is being opened and closed. Also look into hand washing technique. You have the WHO surgical hand washing technique. So adequate time is important. You have to at least wash it for 3 minutes. Then you should also look into the water with which you're using. You have to look for the TDS and microbiological reports regularly in them periodically. And you can also use alcohol-based scrubs after drying your hands thoroughly. And you should wear your gown and gloves properly, not touching the ends. You should also monitor the staff and train the staff in detail about these things. So when it comes to disposables, it is good to always maintain separate disposables, including phacotex, BSS bottles, blades, viscoelastics, Trypan glue, what all consumables we are using. It is always good to note the batch numbers and then maintain a logbook where you write the surgeon name, the order of patients, on which order the patients are operated on the day, the timing at what time they're operated, the indicators which are used and put in the tray of each patient, and the IOL sticker, so that in case you have a sentinel event, you can always have an easy recall procedure. So I was quite surprised that I didn't know any of these indicators, and I should thank Samina ma'am because I attended most of her classes physically and online, where I learned about what indicators we use when we are sterilizing and how the sterilization is done. So it is also quite important that all of us should know that what indicators are used. So these are a must. This is not like a choice that you can either use physical, chemical, or biological. All three are must. And class B autoclave is standard of this thing. And these are the critical variables which we have to look and see if the autoclave is maintaining. So now that we have done the primary prevention, even after doing it thoroughly, if we could not avoid the disease coming up, then we do the secondary prevention, that is early diagnosis and treatment of it. So we have to determine the source first, either is it from the patient's own flora or the surgical instruments, tubing, surgical site, or is there any complication, or is the wound not healing properly? So if you suspect a fungal endophthalmitis, always look into the faulty air conditioning filter systems. When you're looking into gram-negative or a pseudomonas, then look for contaminated fluids or viscoelastics. When you're looking at gram-positive cocci, you have to look at the healthcare personnel or the patient himself. And when there are gram-positive rods, then look for the contamination of the OT. You might have to close the entire operating room before you could find out the reason. So this is one of a case where a 53-year-old female, first post-op day, there's no pain, 6/60. There's mild corneal edema, there's a hypopyon and cells and flare, but the posterior segment was quite okay. The haze is because of the corneal edema. We could not see any cells in the anterior segment, anterior vitreous, and the B scan was normal. So this is also important. It is one of the main differential diagnoses for TARS. So you should also know how you differentiate TARS from endophthalmitis. So these are what you have to look at. The main things are the onset. It happens on the first post-op day within 1 or 2 days. The incubation time for endophthalmitis is little higher, 2 to 7 days. You don't have lid edema. Patient hardly has any pain. The visual acuity is moderate to severe. IOP, there's significant increase. You have corneal edema, limbus to limbus. The pupil is fixed and dilated. The vitreous, there could be mild involvement or no involvement. Culture has always been negative. They respond very well to steroids. So why does this happen? The etiology, it could be right from the Trypan glue, which we use for lens capsule staining, or inadequate flushing of the hand pieces, using enzymatic detergents, using ultrasound baths, then ETO sterilization, or even because of the abnormal pH, which can happen in the intracameral injections which we give, the intraocular lens per se contamination, or there are a few features of patient itself, like type 2 diabetes, hypertension, hyperlipidemia, renal failure. So how do we manage this task? You can either give topical steroids, but at a frequent instillation, and you can always add a or antibiotic, topical antibiotic to it. If you think there is severe fibrin or hypopyon, you can even start up with the oral steroids. You have to always never neglect endophthalmitis in this case. You have to look whether the vitreous is getting involved, whether the patient is deteriorating. And if suspicious, then you always do a microbial culture. So surgical interventions, if it is so severe, then you might have to do an anti-chamber washout, vitrectomy, IOL removal also sometimes. There could be reversible corneal endothelial damage, cystoid macular edema, and secondary glaucoma. So this is how it was, and with topical steroids, the patient responded very well. So this is another case, 60-year-old who was operated elsewhere, who was having recurrent inflammation episodes, and the cornea also decompensated. The patient was left aphakic. There was pigment dispersion, there's anter-segment flare, and there's a membrane also at the pupillary margin. Posterior segment, I could see pigmented cells, and there was mild vitreous hemorrhage, which was confirmed on B scan. So then we did a combined approach. We did a pars plana vitrectomy and a dissect together. So I did a VRS technique where we could clear the vitreous hemorrhage. The vitreous hemorrhage was almost old. Then I had my brother, he's a corneal surgeon. So I finished doing the SF IOL, and followed by that, we placed a tissue, and the set was done. So this is how the patient was, and today he's maintaining around 612. This is 1 week post-op, and now it is almost 3 months, and he's maintaining good vision. So this was a case of corneal decompensation along with TARS, and where we did dissect with SF-IOL. This was another case, a 58-year-old female. This is post-op day 5. They had mild pain, 2/60. Corneal edema was there, limbus to limbus. And you could see very mild hypopyon with cell flare. But B-scan also showed membranous echoes, and there was high reflective dome-shaped echo which was there. And then when I could actually give topical medications, and when the edema came down, and then when I went down and saw, there was a nucleus, a whole nucleus was down in the vitreous. So you should always suspect a sterile reaction sometimes when you have a causative agent. So this is post-op case, post-op with an SF-IOL. So this is another case where a 45-year-old with pain, lid edema, and there was sudden decrease in vision since one day, the post-op 15 days. Anterior segment had flares in cell, mild hypopyon. Posterior segment also had anterior cells 4+ and with membranes. This was hazily seen. This can also confirmed mild echoes. Because they were very mild echoes and we suspected early postoperative endophthalmitis, I gave him intravitreal vancomycin with DEXA, and we did a vitreous sampling. But 2 days post-injection, he improved very well. The vision improved from 3/60 to 636. There's still a mild peripheral vitreous haze, where we gave him a second dose of intravitreal injection. And yesterday I saw him, he's at 618. So this is another picture which I've taken from Dr. Vivek Dhave's presentation paper, where he had shown this case where there's no reaction in the anterior segment, but you could see a white membrane within the bag. So this is a capsular distension syndrome. You should not mistaken it with endophthalmitis. So any case of anterior segment inflammation, always do a B scan. It is very important. Endophthalmitis gives rise to vitreous inflammation. So you see point echoes in the vitreous cavity. So you should always look for RC thickening, posteriorly dislocated lens or IOL, any retinal detachment or choroidal detachment, if any IOL intraocular foreign body is present. And you can also use B-scan to serially monitor after giving the intravitreal injections. So then once you know that it is an endophthalmitis, then you should always do a sampling. You can either take an anterior chamber tap with a 30 gauge needle where you have to place it parallel to the iris and then take the sample, collect the hypopyon or the fibrin exudate. Or you can either always do a vitreous tap using 22 gauge needle, but then if you're pulling the vitreous, there's always risk of retinal detachment. You can always collect the vitreous fluid from the machine itself after you do the vitrectomy, or you can collect a vitreous biopsy like this by connecting a 3-way cannula to your vitrectomy cutter, and then you can ask the sister or the nurse, scrub nurse who's assisting you to actually collect the fluid in the 1 ml syringe. So these are the various sampling methods which we have, and if you see the vitreous fluid has given more positivity of the culture and gram stain and QH. So once you collect the sample, it is important you run a gram staining and a KOH immediately, because the results are very fast, and you could have a better management of the case. And then you can also inoculate it directly on the blood agar or the chocolate agar and ask your microbiologist to incubate it and look for the colonies. It's always good to do an antibiotic susceptibility because of high risk of antibiotic resistance nowadays. So you should know to what it is sensitive and give the specific antibiotic. Suppose if all these things you do and your culture is still negative, you can always try doing a PCR. So when do you choose intravitreal injections? To buy time. You're not a VR surgeon. You cannot go inside and you're referring the patient, and always give an intravitreal injection and then send the patient. Before you give an intravitreal injection, always make sure you do a B scan to look if there's any retinal detachment or choroidal detachment, because you will deteriorate the patient if you're not doing a B scan. So which is an ideal intravitreal injection? It should be effective against offending organism. It has to be non-toxic to retina. It should have a good half-life and easily available and cost-effective. We usually follow a true drug regimen if it is an acute postoperative endophthalmitis, where we give a gram-positive and a gram-negative coverage. So these are the injections which we have, intravitreal antibiotics, wide range, and these are intravitreal antifungals which we have. We also have newer drugs now because of resistance which we are seeing to antibiotic resistance. Then we can always choose the newer drugs. So how do we choose which one to give? So if it is a gram-positive organism, vancomycin is almost quite effective, and you should try giving vancomycin. And even with vancomycin, it is not coming down and you still have a gram-positive organism, then you can try giving linezolid. And if it is a gram-negative organism, start with ceftazidime or amikacin, 80 to 90% efficacy. If it is failing, then you can always move, and there is no improvement, you can move to the higher antibiotics this way. Then how do you know whether the patient is improving or not? There has to be decrease in lid edema. There has to be increase, little, at least a very little increase in visual acuity. There has to be improvement in his symptoms. And look at anterior and posterior segment. Anterior segment, you have to look at decreasing in the hypopyon, cornea should clear, fibrin should consolidate, pupillary membrane should shrink. In case if you're looking at a posterior segment, then look for red reflex, whether it is getting better, or you could see any disc or first order vessels. Then you should grade according to the visibility of the retinal vessels and disc. So our goal is to kill the organism, arrest the damage secondary to the toxins, arrest the host inflammatory response, and minimize further complications. So this is tertiary prevention. If we could not save the eye in early diagnosis, then at least you have to try saving the eye and a little vision, how much you could. So for that, we could either do an early tap and inject, or you could do a pars plana vitrectomy. In case you're doing a pars plana vitrectomy, either it has to be core or complete, which is better. Whether you want to remove the IOL at the first go, or you also want to inject silicone oil. So it is individualized. If it is an early tap versus pars plana vitrectomy, it is individualized. A VR surgeon has to decide depending on his vision of the fundus examination. If it is an early case, you could still see the fundus, then you can tap and inject because you do not harm much. You're not going inside close to retina and all that, because retina is very friable in cases of endophthalmitis, and there is always a risk of causing an iatrogenic break. The only disadvantage with only injecting is you do not decrease the infection load. So when you have fundus which is totally obscured and you cannot see, you can always do a pars plana vitrectomy so that it will have an earlier recovery, lesser intervention, and greater change in visual acuity. Why do we still prefer pars plana vitrectomy in modern era? Is because we have this minimally invasive vitrectomy surgery, and we have good viewing systems now, and there is increase in number of VR surgeons also. So now we have to decide whether you want to do only core. Core is where you only debulk the center, or you want to do a complete vitrectomy. So it is always good to do a complete vitrectomy because the inflammatory debris being heavier, they're always trying to settle over the posterior pole. And you start in using PVT, you have complete removal of even these inflammatory debris, which are very close to the posterior. So this was a case of acute endophthalmitis where you could see there is a already retinitis patch which is involving the macula. So I just debulked and did a core vitrectomy in this patient. Whether you want to remove the IOL or not, IOL we usually always remove whether it is a fungal endophthalmitis. When you see a chronic delayed endophthalmitis, most commonly the propionobacterium, you can try cutting the posterior capsule and do it. And even with that, if you see recurrences, it is always good to remove even in a case of propionobacterium. In most of the acute postoperative endophthalmitis cases, being bacterial, you usually don't remove the IOL, but if you see recurrences, as a secondary management, you can remove the IOL. Always when you're explanting the IOL, you should always think about the aphakic correction, the fate of other eye, and the patient might require a secondary IOL and its risks. So this was a case of propionobacterium where a patient was getting recurrent anterior segment inflammations for past 6 months. So then I had to go ahead and then I cut the thing and I also removed the IOL and patient is doing fine. Then the last, when do we inject silicone oil? When you want to compartmentalize the eye, the anterior segment, you usually can give topical medication. Posterior segment, when you have already filled with silicone oil, which is imprintable to the organism, and then you have the retinal surface inflammation, then you can give systemic drugs to them. Systemic antibiotics, oral ciprofloxacin for bacterial endophthalmitis, and in case you have fungal endophthalmitis, you can give itraconazole also for days of 21 days. When you're sure and your culture shows it is negative for fungal and it is bacterial, then you can also inject intravitreal dexamethasone. Thank you.
Thank you so much, Dr. Neha. It was a comprehensive overview of endophthalmitis prevention and treatment. Very much wanted. I think we have come to the end of this session. There's a slight change in the schedule again. I would say it's a change, but it's in continuation with this. The next talk is going to be cost of poor quality. That's going to be given to us by none other than Dr. Samina Zamindar. She's all into quality. So talking about Dr. Samina Zamindar, she is a cataract surgeon and a comprehensive ophthalmologist. She is the founder of Zamindar Microsurgical Eye Center. She's a prolific cataract surgeon, one of the early ones to take on to phacoemulsification. She is also into a lot of quality. I have attended her the course she has in her place. I was so amazed to see in a small setup, she has everything possible and it's all so well managed. And I think she is one person who has only ladies as her staff. That's again very encouraging and very inspiring. So she's going to talk all about the cost of poor quality. Over to you, Dr. Samina.
Thank you, Dr. Madhavi, for this opportunity. And thank you, APOS, for giving me this opportunity. Dr. Sujata, Dr. Raju. I'm so glad and I'm so honored that I'm sharing the same stage as stalwarts here, Subhadra ma'am, and all of you over here. So yeah, without wasting any time, I'll go to my presentation. Is my presentation clearly visible now?
Yeah, you're audible and your screen is
okay. Visible. Thank you. Thank you so much. So yeah, when we talk about the cost of poor quality, let me get down to what do we actually mean by that. We have to understand that an unsatisfied patient is the only reason for any negative publicity for any healthcare organization. The negative publicity leads external and internal damages. Externally, we can bad reputation to the hospital, decreased footfalls for OPD and surgery, decrease in revenue, legal issues might come up. And internally, of course, the stress levels amongst the staff increases. There's a decreased job satisfaction, an increase in absenteeism and attrition. So when we talk about attrition, it's not always about money or the salaries what they get. It's also about lack of gratitude, lack of job satisfaction, lack of respect and dignity at work, right? So these are the few causes why we have to deal with poor quality. And now when we have to talk about a better quality, what does that entail? Cost of prevention. quality planning, infrastructural change, staff training, development of quality management systems in the organization, conducting internal audits, quality control meetings. Now, all these things, it sounds very daunting, isn't it? It sounds very difficult. It sounds as if, oh my God, will I be able to do, especially if you're an entrepreneur and you're running your own practice? That's the reason why the question that why don't we have enough successful women entrepreneurs in India? So let's come back and talk about the root cause. The root cause here could be your own self. Are you limiting your own self and telling your own self that you cannot do it? There's something like the power of not yet. The moment you say, I can't do it, you decide that you cannot do it and you are stalled. But if you say, no, I can't do it, I can't do it yet, not yet, but definitely someday I'm going to do this. So when you open that window in your mind, a lot of possibilities are open now for you to think, yes, when can I do it? And you will start listening to everything what others say, and you start observing what others are doing. And before you start your journey, see the perception, how it seems. It's a very uphill task. I can't do it. But once you've started, see how it looks. People will join you because of your great vision. You know, they will feel, yes, let me join this organization. I love this person. I feel she has got a great vision. But if you don't have your systems and structures and processes in place, if you don't show leadership in your organization, they will leave because of your poor leadership. I want to bring in these two human beings into your lives. Introduce them. Who are they? Gay Hendricks and Dr. Kathleen Hendricks. They are the author of this wonderful book known as The Big Leap. Start small and think big. What does the big leap say? The big leap says exactly what Subhadra ma'am told us just now, what Madhu ma'am told us, and what Chaitra also brought in the panel discussion, that you have to structure your life. You have only that much time, only 24 hours in a day. And how do you make the most out of it? That is what the big leap says. And I want each one of you, if you get a chance to grab a copy of this book, please read it, because it talks about this. It talks about dividing your life into 4 distinct zones. The first zone is the zone of incompetence. Are you still trapped in doing things which other people are better at home and at work? HR activity, accounts, right? These activities will waste your time and cause frustration. Kindly, please leave this today. You cannot live out of your zone of incompetence. You have to get out of it. Things which other people are better than you, and you are still doing those things. Then comes to your zone of competence. You are good at these activities, and so are other people, right? These activities will make you feel very busy and productive. Like, for example, in the hospital, running the OPD, doing patient counseling, doing the job of an optometrist. But it's keeping you away from your life's goals. If other people are as good as you in doing these activities, you have to allow the other people to do this. What is the next zone? The zone of excellence, of course. You perform these activities extremely well. They're a great source of your livelihood, say, operating. And maybe other people don't do it as well as what you do because you've not looked for them. Family, friends, organization wants us to be here to give us stability and security. But it is a very dangerous zone because it will trap you into your comfort zone. You realize now that I spoke about the zone of incompetence, competence, and excellence, and I'm telling you that your zone of excellence is your comfort zone. You will have to muster the courage to come out of this zone. So what is the zone what we are looking at? That's your zone of genius. That's your zone of life that you get up in the morning and you're excited to jump out of your bed and go to work. That's your ultimate calling path to happiness, right? Whatever that is. So try and go in the pursuit of that, whatever it could be. And deep down, we all have some interest. You will have to look for that also and make time for these interests. If you don't, this calling will grow louder and it will have a conflict and you will never be a satisfied person. So friends, let's talk about design thinking changes. What is design thinking? We hear this word very often in a city like Bangalore, definitely. It is a patient-centric approach to problem solving, focusing and understanding the patient's needs and creating right solutions. These solutions that meet those needs in an innovative and a user-friendly manner. Now, how do you decipher this jargon which I've just told you? Listen to your patients. Meet with your patients. Meet with your happy patients. Meet with your frustrated patients. Don't take just feedbacks, on a paper like good, average, excellent. No, you need to have time. You need to have senior people, or you yourself will have to spare time to talk and understand what is lacking and bring in empathy, creativity, and experimentation to improve patient satisfaction. Make delighted patients. Every patient who goes out of your center should be your ambassador. That is what we call it as a patient-centric approach. Whatever you do in your organization, the patient is in the center of all those thinking and action. Some interesting theories I would like to share as leaders in our own organizations and maybe in other organizations also, when you are in a leadership position. This is a theory of X and Y on motivation by Douglas McGregor. What does he talk? It's very interesting. Theory X and theory Y. Theory X assumes that employees dislike work, they lack ambition, they avoid responsibilities and must be directed and coerced to perform. Do you want to get trapped here, or do you want to now believe in theory Y that assumes that employees they like work, they seek responsibilities, they're capable of making decisions, they exercise self-control and are committed to goals? When you start moving to the theory Y, what happens? Magic happens. Theory X encourages use of tight control and supervision. It implies that employees are reluctant to organizational change, so it does not encourage innovation. Nobody would want to come and tell you a Kaizen idea, a creative idea, because they are all so fearful. Theory Y implies that managers will create and encourage a work environment that gives opportunities for your staff to take initiative and self-direction. So any organization which has to grow, the leaders have to believe in theory Y. I have heard many people complaining to me, no, we teach them, but they are so this, they don't want to learn. What can we do? Please don't be a part of the problem. As leaders, you have to be a part of the solution. And how do you look at questions and answers? Yeah. You have to find out when things are not working out. You have to make simple diagnosis, right? Do people know what exactly has to be done? Do people know what it is to be done, but not know how it is to be done? Are people facing any hurdle or have a reason for hesitation? And if people are unwilling to follow the process, why? Before judging your staff or getting into, oh, they will not do, or they are like that, try to find out what is the root of the problem. So when you identify a problem and have focused solutions, you have to ask the right questions. See, there are 3 sets of questions I've given up over here. First set of question, you ask somebody, why did this happen? Look at another option. What would you like to say about this? Second set, who is responsible for the current situation? Instead of that, you ask, how can we learn from this? Third set, what are your obstacles? Instead of that, you say, what is the first step now you will do after this? What is your first step? This is the ownership, accountability, and respect what you give to your staff, the way you ask the questions. and let them work out of loyalty, let them work out of accountability and ownership rather than work out of fear. This is my team over here. And let me tell you that I started on a two-wheeler right back in the year 1997 with a mobile eye clinic. Today, we have 3 NABH accredited eye hospitals in Bangalore. And this team worked together and gave us the Association of Healthcare Providers of India's Patient Friendly Award for 2022. This was possible because we believed that together we can make a change. Thank you so much. I hope that this helps anybody who wants to go into the next level and think that they can do it and not spend money by spending on poor quality, but spending on the cost for the good quality.
Thank you so much, Dr. Samina. Such a motivating talk. Actually, it's inspiring us to do better, come out of our comfort zone, go to excellence, and then to genius, and then, really take it forward. I have listened to you talk before also. I've come to your institute. I've, gone through that 2 days of program. So recently, we also got our NABH accreditation. It seems like a real chore in the beginning or a task to be done, but then it becomes a habit with each passing day. If somebody does it other way, you are not happy with it. Why can't you follow? It's a very simple rule and it's for the good of everyone. The signing coming right from the number of signs you have to put every day. It's okay. It's just a 2-minute job maybe, but then it keeps all the protocols and SOPs in place. Thank you so much for that.
Thank you, Dr. Madhvi, for the opportunity. Thanks. And thanks for accommodating earlier. I'm here for some more time.
Yeah. So now that we have come to the end of this session also, and we have Dr. Subhadra ma'am also here and Neha and Dr. Chaitra also, I think. So any more questions in this session and to Dr. Samina herself? She conducts a wonderful course from time to time on quality. So any of you who have not attended should attend it. It's a nice place she has there. Any questions to Dr. Samina or to Subhadra ma'am, Dr. Neha? Any comments?
I have put some of the thoughts on and off in the chat box. I think people can read that.
Oh, okay.
So they can just read it so that we can go ahead with the next topic.
Yeah, thanks for that, ma'am. Okay, so let us move on with the program. So the next talk is going to be by Dr. Hemlata G. She's going to talk on post-cataract surgery corneal edema management. Talking about the speaker, Dr. Hemlata comes from the town of Eluru. She has done her MBBS and her MS from Regional Eye Institute, Visakhapatnam. She's done a cornea and microsurgery fellowship from Arvind Eye Hospital, Madurai. She's done her DSEC skill transfer as well as ocular surface reconstruction courses from LVP and her advanced training in FECO from the Alcon at Shishruta Eye Hospital, Kolkata. In a small town of city or town of Eluru, she's doing wonderful job. She's brought a lot of accolades to the place where she's working. She's heading the cataract and refractive surgery section in Shankara Netra Chikitsalaya at Eluru. Over to you, Dr. Hemlata. Welcome.
Thank you, ma'am. Thank you for the introduction. I hope my voice is audible.
Yes, you're audible and your slides are visible.
Thank you very much, ma'am, for giving me this wonderful opportunity to speak along with great stalwarts, women stalwarts. And so today my topic is management of post-cataract surgery corneal edema. And I'm Director Cornea Refractive Services, Senkanatra Chikitsalaya in Eluru. So coming to my topic, slides are not moving.
Maybe you can unshare and share again, because the first slide is being seen. Put it on slideshow.
Yeah, I think it is moving.
Okay.
If you see this series of various presentations, So there are varieties of corneal edema presentation, as you can see in these pictures. They're either complete edema or they can be sectoral edema or a partial edema, like in these pictures. So these are broadly classified into preoperative, intraoperative, and postoperative. But today I'll be discussing mainly on the patient's factors and the surgeon factors which are causing these corneal edema. So if you see the preoperative, hard cataract is one important factor, intraoperative instrument trauma, excessive use of phaco power, and desmus membrane detachment. In the post-operative period, the IOL causing endothelial touch and raised intraocular pressure. Last but not least, a complicated surgery with vitreous in anterior chamber. So if you see these pictures from extreme left to right, these are NS2 grade cataract in the left, and in the middle mature cataract, and in the right very hard cataract. And these three surgeries were operated by the same surgeon on the same day. And you can see the post-operative pictures. On the extreme left, there is clear cornea, and in the middle, there is mild corneal edema, and on the right side, there is dense corneal edema, especially in the superior part. So indicating that as the grade of the cataract increases, there are more chances of increase in corneal edema, even in experienced hands. Coming to the case 2, so this is an anterior chamber IOL, which is posterior chamber IOL, which is placed in anterior chamber, which is loose, and it is causing endothelial touch, leading to corneal edema. This is another case where there is corneal edema more than 3/4 of the cornea, and on slit lamp examination show desmus membrane detachment. So if you see the medical management, always we tend to start with increased frequency of topical steroids. These topical steroids try to maximize the effect of endothelial cells which are present after the cataract surgery, which can be combined with systemic steroids, which increase intraocular inflammation and endothelial loss. Hypertonic agents, especially sodium chloride 5% and 6% ointment, they try to increase the osmolarity of the tear film and tend to drag the fluid and makes the cornea clear. Especially in patients who have raised intraocular pressure and which is causing corneal edema, can be given anti-glaucoma medications and thereby increase the corneal clarity. The extended wear hydrophilic bandage contact lens, though don't have any effect on the pathology, but they act as barrier on the surface of the cornea and they reduce pain due to epithelial bullae. So in a prospective comparative trial done by Nezovic et al., where they have given Hypersol 5% in 70 eyes of bullous keratopathy, they have seen improvement in early cases where there was no improvement in advanced cases. In another prospective observational study, where both topical and pulse therapy was given in 32 eyes post-cataract surgery, they have done this in both hard cataract and soft cataract eyes. And in hard cataract eyes, again, they have divided into study and control group, where pulse and topical was given in study, and in the control group, only topical steroids were given. And they have observed recovery of visual function faster in the study group. And in the soft cataract patient, again in the study group where pulse and topical were given, there is smaller loss of endothelial cells. So indicating that definitely there is a role of systemic steroids in patients with corneal edema. So the main emphasis today is DM detachment, because this is the most commonly unidentified but easily manageable complication in a patient with post-cataract surgery. So if you see the prevalence, it is around 0.1% in manual SICS and 0.04% in phacoemulsification patients. So especially a budding surgeon should avoid taking these kind of cases, because these patients have a very thick desmus membrane which can be easily stripped while entering into the anterior chamber, either a phaco probe or any entry blades. So coming to the configuration, especially patients with hammock configuration, that is separation is at the corneal ports of entry, a better prognosis and reattachment rate compared to patients who have a complete tear with 2 or more flaps. You should try to identify the interface material because patients who have viscoelastic or bled in the interface tend to have poor reattachment rate compared to patients who have air or saline. Anterior segment OCT is very helpful in identifying these patients who have poor prognosis, like a patient who develops loose flap with a tear, and patients with DM loss with a detachment, and patients who have iris attachment at the DM and who have scroll DM. Because in these patients, the prognosis is poor. So at least every patient, we should try to do anterior segment OCT before going to the surgery. So extent of DM detachment is also very important because patients who have partial DM detachment have better prognosis compared to the complete detachment. So the surgical management for DM detachment is very simple. Just we have to identify an area where the DM is attached and give a small side port. And then with the help of take care that when you're entering into the anterior chamber, don't strip the DM, give your incision posteriorly so you don't strip through the DM. With the help of irrigating cannula, inject air which completely fills the anterior chamber. After filling, give a thorough massage at least for 2 to 3 minutes. Wait at least for 5 to 8 minutes so that your cornea clears reasonably well. After that, try to decompress. We are not giving a peripheral iridectomy. Then try to decompress the air as and when immediately after 8 to 10 minutes. You can see here the cornea has reasonably well cleared, and in some of the patients where the DM detachment is long standing, try to give a venting incision. This venting incision is given with a 23 gauge needle at the site where there is maximum separation after injection of the air bubble. Try to see the egress of fluid from the venting incision. So with these tips, you can see this patient has cleared very well with just air injection on day 1, and this is at 1 week. So this is another patient where referred, and this patient was repeatedly done air bubbling, but still the patient did not clear and he was referred. And when I saw the anterior segment OCT, still there is a DM detachment with the tear. And I went ahead and did air bubbling, and you can see the cornea has reasonably cleared and the patient is happy, and the corneal edema has also reduced. So this patient again is a hammock configuration where the edema is at the ports of entry. These are the kind of patients where they can be observed at least for 2 to 3 weeks, and this patient over a period of time cleared very well and did not require any surgery. So Kumar et al., they have come up with this HELP protocol, that is height, extent, length, and pupil-based protocol. They have divided cornea into 3 zones. The zone 1 is up to 5 mm in diameter. Zone 2 is 5 to 8, and zone 3 is more than 8 mm. And depending on the height of the detachment, they have divided into less than 100 microns, 100 to 300 microns, and more than 300 microns. So they have managed some of the patients medically and some patients surgically. So patients who had DMD less than 1 mm extent and less than 100 microns high, or patients DM detachment 1 to 2 mm and 100 to 300 microns in zone 2 and 3, and DMD more than 2 mm and more than 300 microns in zone 3, they are managed medically. Whereas patients who had DM detachment more than 2 mm and more than 300 microns zone high in zone 1 and 2 were managed surgically. They have seen almost a similar reattachment rate in both the groups, but the corrected distant visual acuity was much better in patients who were managed surgically. So to summarize these, the final management points were First, give a paracentesis at the site where the DM is attached. Peripheral iridotomy basing on surgeon's preference, and then removing corneal epithelium at the site of venting incision to prevent epithelial ingrowth. And this should be given away from visual axis and at the site of maximum separation, and no fluid egress from the site of incision, and complete air fill at the completion of the procedure. So to prevent DM detachment, we should avoid blunt instruments, avoid hypotony, and gentle hydration of the ports after surgery. So every phaco surgeon should have these tips. Use a very high quality dispersive viscoelastic. Give a clean architecture main incision. Don't use the technique which utilizes minimum phaco energy, that is chop technique. Emulsification should be done in the bag or at iris plane, and less fluid. At least try to use less than 100 ml fluid inside the eye, because the more amount of fluid we use, the more chances of corneal edema on day one. And lift your IOL always and remove viscoelastic from behind IOL, and avoid large white spot hydration, which are the main reasons for the DM detachment, especially even in the hands of experienced surgeons. So these are my final key points to prevent corneal edema in every phaco emulsification case. Thank you very much for giving me this opportunity.
Thank you so much, Amyla. That was a very nice talk, beautifully illustrated. Amyla, when was the last, how much after the surgery, how long after post-op have you seen a DM detachment again get attached with the desmetopexy air?
I have seen even after 2 months, some of the cases I went and ahead and did the rebubbling. I have seen good clearance of cornea.
So we can try that simple technique first rather than go for the other procedures, right?
If you see in anterior segment OCT, there is DM separated. Definitely you can try this before going into endothelial keratoplasty.
Okay. So thank you, Himlata. Let us move on to our next talk. We have the next topic is smile tips and tricks for a beginner. To give this talk, we have Dr. Alpa with us. Dr. Alpa Atul Purabia, she has done her MS and she's also a fellow in the cornea and anterior segment from LV Prasad. She's done her she's a refractive cataract and cornea surgeon. At present, she had a very nice, she took care of the entire refractive surgery department at Maxivision for quite some time. And then she was with Apollo Spectra. And now she is the medical director and she's the chief surgeon at American Laser Eye Hospital, Hyderabad. She's also the state head for WAS, Telangana. Welcome, Dr. Alpa. Please give us your tips on smile.
Is my slide visible? Am I audible?
Yes, you're audible and your slides are visible.
Thanks, Dr. Madhavi and APOS for providing me this opportunity. Under laser refractive surgery armamentarium, we have many techniques available on different platforms. And today I will be speaking on relaxed smile procedure tips and tricks for the beginner. Relax means refractive lenticle extraction. It is available on Visumax 500 platform from the Zeiss company. And now they have launched Visumax 800 also. Under relax umbrella, there are basically two techniques, flex and smile. Before I go into the smile technique, let us first understand the relax flex procedure. This technique, I personally believe, is very, very important for those people who want to start doing the smile surgery. Here, the refractive lenticle is created along with the Femto flap. So rather than lifting the whole flap, you just lift the small incision besides the hinge and go inside and remove the refractive lenticle as if you are doing through the smile incision, which is a smaller incision. By chance you are not able to separate the lenticule or remove the lenticule, you can always lift fully, flap fully, and then you can easily separate the lenticule and position the flap back like as you do in the LASIK surgery. Once you feel confident with the relax flex procedure, you can actually start doing the smile surgery. So in smile surgery with femtosecond laser, the lenticule and excess cut is created in one step. Then manually it is separated through the small incision and removed, and then the incision is sealed. So this is how the refractive lenticle cut is made. In the green color, you can see the lenticle cut, which is a posterior cut made, and which actually happens from the periphery to center. Then the lenticle side cut is made, which is 15 micron in thickness, which is company recommendation. But you can increase or decrease the thickness. Suppose if you have a little borderline thickness and you want to save the RST, then you can increase your lenticle side cut by 5 micron. Or if you have small power correction and you want to increase the lenticle thickness, you can make it something like 20 micron. Though I personally feel by changing this, it doesn't help you much in feeling of the lenticle. Then after that, the cap cut happens, which is here shown in the blue color, which actually goes 1 millimeter beyond the posterior cut. And it has a thickness, we call it cap thickness, which is like 100 to 140 micrometer. Generally, I keep 110 micron thickness, but whenever I have a borderline thickness, I do keep 100 micron thickness also. And then last incision cut happens, which is something like 2 to 4 millimeter in size. So this is how the smile procedure happens. After successful docking from periphery to center, a posterior cut happens, then the side cut, then from center to periphery anterior cut, which goes 1 millimeter beyond the posterior cut, and then the incision. Once the femto pass is over, this is how the cornea looks. First, the incision is lifted, then both the planes are identified, and refractive lenticle is separated and removed through the small incision, and incision is sealed. So for successful smile surgery, these are the important steps you have to remember. The lenticle age and plane identification and smooth separation is the most crucial step of the surgery. The time taken for surgery will directly impact your outcome. Ideally, you should finish one eye per 4 minutes. For patients who move their eyes a lot, you can actually open other eye for them to fixate, or you can remove the central bubble by a little bit tapping over the cornea so that then they can fix from that particular eye. The first step is lift the incision slightly vertically. Then I generally do go to left side and separate my anterior plane, then shift to the right side and separate my posterior plane. And then the lenticle separation starts. By default, you have to separate anterior plane first, because by mistake, if you go into the posterior plane, then lenticle is actually stuck on the cap, and then it becomes very loose and very difficult to separate. You don't have a good hold over the lenticle to separate it from the cap. But still, it is a little tricky situation, but you will be able to manage it. But if you do it from the anterior first and posterior plane first, it is very easy to remove the lenticle. This is Dr. Susan Chekhov has explained this diagram for the posterior plane separation. And I personally believe those who are starting smile surgery, this is a very, very good way to start the posterior plane separation. Here, the small segments are removed, and the segments which are very close to the incision, they are removed last. So throughout the posterior plane separation, you have a good support, and you have a nice way you can actually separate the posterior plane. And the last separation, if it is not possible, you can still remove it as if you are doing the raxis. So you have to go from incision towards the inferior part of the cornea. So in smile procedure, 0.5 to 10 diopter power correction is possible, and up to 5 cylinder power is possible. But for those who are beginning smile surgery, I would recommend that you should try to correct power who are like more than 3 diopter power, because then you have a good enough thickness of the lenticle for your field to have a good enough thickness of the lenticle, and separation of the anterior and posterior plane also you can easily identify. Be careful with the cylinder power, because in the Visumax 500 platform, cyclotorsion component is not taken care of. So you have to actually manually do cyclotorsion, which can be sometimes tricky. Here, recommended range of the optical zone is between 6 to 7 millimeter. In SMILE procedure, we follow Munnerlin formula for the spherical profile. You have to keep at least 300 micron residual bed. Always make sure your MPTA is less than 40% and check your Endorsement ectasia risk. Generally, in Zeiss platform, there are 3 PIs available. And according to the white to white, you are going to decide which PI you are going to use. But for the SMILE, by default, you are going to use small PI. Suppose you have a very large white to white and you are trying to increase the PI size, then be careful because the suction loss, chances of suction loss increases, which is the complication we always worry when we do the SMILE procedure. This is how the lenticle cap and incision parameters are entered. After entering the power, cornea thickness, and the K reading, you decide the optical zone size. Like here, I have entered 6.5. So my cap size will be 1 millimeter more. So cap size will become 7.5 millimeter. Thickness, cap thickness, I have taken 110 micron. Suppose if you enter cylinder power, then there is something called transition zone. Normally spherical power, it is 0, but in case of the cylinder power, it is 0.1, which you don't need to change. And minimum thickness is 15 micron. Incision here, I have taken 4 millimeter. Initially, you can do more than 4 millimeter incision also. Once you become confident, you can actually decrease your incision size. This is how the energy parameter looks. Again, you don't have to change anything here. And the right side is the last screen, which shows you before starting your SMILE surgery. Once you are okay with this, you can start your procedure. So let us understand what are the complications or difficulty in SMILE surgery. Generally, they are femtosecond or lenticle related. Most important is suction loss. And second is opaque bubble layer, which interferes in the laser pass, which can cause sticky or difficult lift. Or you have a dark spot or dry spot. Again, this is a very, very common problem with the SMILE surgery. Whenever you have a dry spot over the cornea or debris, this will cause dark spot in the laser pass, and this can cause a difficult or sticky lift. A shift in the cleavage plane due to sudden shift of the eye under the contact VI. Lenticle can be stuck anteriorly or posteriorly, wrong cleavage plane while separating the lenticle, accidental tearing of the lenticle and retained piece, accidental cap tear, epithelial abrasion, especially at the incision, accidental extension of the incision. You can have a loose epithelium or an epithelial defect when you are using too much of the topical anesthesia during surgery, or you have a longer surgical time to separate and remove the lenticle. You can have a longer visual recovery because of the too much manipulation during the lenticle removal. So in the initial stage of your surgery, you may have that patients are not able to read next day 6x6 and a couple of days they are taking to get back to become normal because of the manipulation you have done during surgery. But with experience and with the good hand, you can actually get the next day also good vision like what you are getting in the factory LASIK surgery. How to achieve the optical outcome? The most important, use the small PI. Two most important complication, as I already told you, we worry is suction loss and dark spot, and here the prevention is better than cure. So cornea should not be too wet or too dry before you start the docking. The causes for suction loss includes uncooperative patient, inexperienced surgeon, and rarely difficult anatomy. So identify that. So for perfect docking, make sure you have explained the procedure in detail before you start the surgery so that patient is very much cooperating during the surgery. Select small PI, check the PI for the debris, air bubble, and foreign body before you start the procedure. Cornea should not be too dry or too wet. You have to do soft and well-centered docking. Here in this Zeiss machine, there is no scleral ring. So patients are actually very, very comfortable, and throughout the surgery, the vision is maintained. The suction pressure is around 35 millimeter of the mercury. You have to apply suction with the 80 to 90% of the application on tear meniscus with the PI. If you try to go beyond 90%, then you have a very, very hard docking. And again, you can have a sticky lift with this. These are the general points to achieve the optimal outcome in laser refractive surgery, which are common for all laser refractive surgery. Always check machine and laser treatment parameters. Follow machine guidelines strictly. Use same criteria to evaluate the patient. Perfect lenticle age and plane delineation is very important. Smooth lenticle separation and removal is very important. Examine lenticle after surgery. Tight cap opposition at the end of the surgery is very important. Slit lamp examination after surgery and post-op instruction to the patient. This is the company provided guideline where if you cannot find the lenticle, what is the way you can go ahead. So in smile surgery, if it is less than 3 power, you can go ahead with the PRK surgery, or you can postpone the surgery and later on you can do PRK or femto. And in case of the suction, again, the machine guides you very well what is the next step you have to do and how you can proceed the surgery. If it is less than 10% lenticle cut when the suction loss happens, you can repeat the surgery from beginning. And if it is more than 10%, then you have to convert it to the femto by circle formula. That is a license you have to buy, which is available on the Zeiss platform. And if it is during the lenticle side cut or during the cap cut or during the cap side cut, you can actually reduce the parameter and you can go ahead with the surgery. The post-operative side effect and complications are same like other laser refractive surgery, and you have to manage them same way. Thank you.
Thank you, Dr. Alpa, for an overview and tips for a beginner. So encouraging us to try a new procedure, which is now most sought after. We have completed this section also of cataract and refractive surgery. Any comments or any question to the speakers? The next section, we are having Dr. Mohita Sharma to give us a talk on opportunities and objective of Women Ophthalmic Society was, but due to some other commitment, she's unable to join us. I think she has entrusted the job to be again continued by Dr. Alpa, who will be ably doing it. She's also a state head, as I already mentioned. She's the state head of Telangana Women Ophthalmic Society. Alpa, just give us I think you can talk on behalf of Dr. Mohita.
Am I audible? Am I audible?
Yes, you are. You are.
Okay. Because I'm speaking on the last moment, I will not be able to do proper justice, but I'll share as much as possible what WS is about. My slides are moving.
No, the slides are not. Yeah. Yes. Okay. It's moving.
So WS is like Women Ophthalmology Society, which was started 7 years back. Now we have 2,500 members and 18 state chapters. It is one of the fastest growing society in India. It is a little bit different. Like we are kind of activities done here is a little bit different than all other ophthalmic organizations we are either member of or we are seeing them. We have a speaker job opportunities where we have a speaker resource center where anybody can send their topic or preferred conferences with the short CV even today. And selection is based on the merit. With this, you can project your good work, gain more confidence, and enhance your skill and knowledge. Also, this will be helpful in your networking also, which is very, very important factor in your practice. We have done till today 25 activities all over India. You can see some of the photograph. This is actually the first state conference done by Karnataka state when the WS was initiated. This is a Hyderabad chapter meeting. And you can see the different conferences, session photos. This was again Hyderabad annual conference in 2018, where first time mentored live surgeries were done, where the mentee actually performed the surgery along with the mentors, and you can see the beaming face of the mentor and mentee on the camera. programs on our annual conference. So this is one of our initiative called Preo, where we have a breakfast meeting and we arrange yoga meditation during that time and also sessions on the practice management. And you can see some of the photographs of that. These are state competitive session photographs. So these are the highlights of our annual conferences. We have a mentored live surgery session, state competitive academic sessions, Sharp Tech innovation sessions, where we actually project people who have done some innovations. And it is a very, very nice way to learn whatever new things are happening. And it also motivates others to focus on innovation. Research session, basically push women ophthalmologists in research, leadership, medical legal aspect, mentor-mentee session, women health and yoga session. So we have initiated mentor-mentee program, which was long back it has started. We have actually galaxy of mentor and you can select whatever you want to learn. Depending on that, the mentor will be assigned to you. And the mentor will help you in whatever you are looking for to develop that particular thing in your professional field. And we have a mentor-mentee, we have a meet your mentor session also in annual conference, where you can actually physically, because generally this will be done on online session, but you can physically meet your mentor for your queries and doubt in annual conference. We have a PG learning programs. And last year we did so many state competitive competitive session for the residents from many chapters. It was organized. Recently we have launched Project Archana. This was started after the sad demise of Dr. Archana in Rajasthan. Basically, it is to convey the message that you are not alone in your professional journey. And through this project, we are actually doing online interactive sessions about how to deal with the crisis and emergency helpline for the crisis management. And some state level have done the sensitization meeting with the police and media in this kind of situations. As during this project, we have actually learned how to deal with the crisis, like keep your cool, physically, mentally, and legally. You have to protect yourself. Then emergency helpline number, always keep a phone of a friend in the dire need of help. You can contact your friend who can actually help you at that time when your state of the mind is kind of very much worried or in a very bad situation. And some of the state have done this activity where they have sensitized the media and police about the situation at the hospitals, especially attacks on the doctor. Then another project we are going to work on is Project Shakti. It is basically to support the aggrieved female doctor. It is basically to help them to deal with the gender bias at the workplace, to deal with the sexual harassment at the workplace, and to form we are planning to form a grievance redressal committee or gender committee at the level of WS. Then there is another important project going on, that is Women in Research. It was started with so many people actually presented the studies, and 5 initial studies were actually started. And we have actually done the training along with Dr. Sabyasachi Sengupta, and almost for the research, for those women who want to understand research and want to start research, for them, we have done this training course, and almost 100 women ophthalmologists attended that. We have WS Ethics Committee also. So those people who are worried and don't know how to start the project, you can approach this committee and you can start your research. WS is involved in molecular research along with the help of the Narayan Netralaya, and again training for that research. You can see the photograph. We have also launched Webinar website where we have national and international opportunities for research are there. And the speaker, all the research mentors names are also available there. If you are interested, you can go through this website. We have collaborated all over the world with different organizations and different women ophthalmologists organization for this Women in Research program. And recently we have started this RED group, that is Red Eye Disease Group, Rare Eye Disease Group, and IGO also published Red Eye Disease volume, and women ophthalmology, so many women ophthalmologists along with WS actually actively participated in successfully publishing this issue. So rare eye diseases means what we are going to do is we are identifying certain rare diseases. We are going to create national registry for that, provide them low vision aid, support group for them, rehabilitation, counseling, and focus on the genetic testing and therapy for them. Then there is something called WS Care, where we are going to focus on equal opportunities and skill for all women ophthalmologists. So we are we are going to create kind of fellowships for women ophthalmologists who wants to improve their skill and support to the women ophthalmologists and skill enhancement and mentoring them. There is something called Women Ophthalmologists Worldwide, which was again recently launched. It was in collaboration of the so many women organizations, especially ophthalmologist organization from across the world. And we held our first conference in Bangalore. That was a WOW conference. This was a WOW conference in Bangalore. These are the again photographs of that conference. Thank you.
Thank you so much, Alpa, for that overview of WAS, the opportunities and our objectives. So since due to paucity of time, let us go ahead with the program. So next speaker is going to be Dr. Himabindu Nair. She's going to talk on traumatic glaucoma. Dr. Himabindu, she is a consultant glaucoma and cataract with Max Vision Eye Hospital at Visakhapatnam. Over to you, Dr. Himabindu. Bindu, unmute yourself. Please unmute yourself.
Thank you, Dr. Madhavi, for the opportunity. Can you see my slides?
No, not yet.
Not yet.
Are you doing the share screen? In the middle of your screen, lower part, there's a green button, share screen. Yeah.
Now are you able to see my slides?
Yes, yes. It's in a PPT mode. Just do a slideshow. Yes.
So, good afternoon, everyone. I'm going to speak about traumatic glaucoma. So traumatic glaucoma is a type of secondary glaucoma that develops following injury to the eye. So this subtype involves several mechanisms that may act singly or in combination with each other to produce increased intraocular pressure. So it is important to consider all pathophysiological mechanisms as they influence the management of patients. The traumatic glaucoma is more commonly seen in young active males because of injuries related to sports or assault. It can be seen in elderly patients also. Following a fall, they can incur blunt injuries. So the risk of developing glaucoma after blunt injuries is slightly more compared to the penetrating injuries. And the presentation of glaucoma may be acute or many years following trauma. So if you want to classify traumatic glaucomas, it can be classified as post-mechanical injuries, like post-blunt injury or post-penetrating injury, following chemical burns, thermal burns, electric shock, and radiation. If you look at the etiology for the raised intraocular pressure, it could be varied because the pathophysiological mechanisms are many and the healing responses that occur after the injuries are varied. So several of these mechanisms might be present at the same time, contributing to the increased intraocular pressure. So it is important to recognize these mechanisms so that we can plan our management. Like in mechanical injuries, there can be inflammatory response, hyphema, iridodialysis, anterior syncytial formation, angle recession, or retained intraocular foreign body. If there is an iridodialysis with hyphema, the chances of angle recession are more. If there is a cyclodialysis, then you're looking at an eye with low intraocular pressure rather than high. So when looking at the different kinds of traumatic glaucomas, different types of injuries. The most common one is the blunt injury. So in blunt injury, you have an early onset glaucoma and a late presentation of increased intraocular pressure. Early onset glaucoma, the causes are trabecular meshwork disruption, hyphema, traumatic iritis, and choroidal hemorrhage. In trabecular meshwork disruption, it can get mechanically disrupted, causing superficial tears or full thickness tears, which are easily visible on the gonioscopy. So what happens is because of the tear of the trabecular meshwork, the outflow of the aqueous is affected, as well as there is an inflammatory response, which is clogging the trabecular meshwork and further decreasing the outflow of intraocular pressure. So this causes glaucoma in acute phases of blunt injury. Coming to hyphema, the source of bleeding is from two mechanisms. It is the initial impact of the trauma, which leads to antero-posterior compression of the globe with simultaneous equatorial expansion. So this causes tearing of the blood vessels in ciliary body and iris trauma, causing the bleed. Sometimes the trauma may not be that severe. The impact may not be that severe, but the blood vessels in the iris and ciliary body, which are fragile, they can bleed, especially in sickle cell patients. Even small amount of bleed in the anterior chamber can lead to very high intraocular pressures. So what happens is this blood accumulates in the trabecular meshwork. It obstructs with this erythrocytes, fibrin, platelets, and inflammatory debris, causing the outflow to reduce. Coming to traumatic iritis, it is the inflammation of iris or trabecular meshwork, which again causes inflammatory responses and reduces the aqueous outflow. Choroidal hemorrhage can cause an acute increase in the intraocular pressure following trauma because of the displacement of iris lens diaphragm, which leads to the pupillary proc and acute angle closure glaucoma. Coming to the late onset causes, angle recession is one of the most known and most common cause for the late onset of glaucoma. Ghost cell glaucoma can occur. Hemolytic glaucoma, hemosiderotic glaucomas are rare. Lens mechanisms like lens dislocation, subluxation can cause late onset glaucoma. Phacolytic glaucomas can also occur at a later stage. Coming to the angle recession glaucoma, angle recession is a tear between the longitudinal and ciliary muscles, which leads to the ciliary body band being widened, like you can see in this. This causes the damage to the trabecular meshwork and scarring, which decreases the outflow of aqueous, leading to increasing the intraocular pressure over time. If the angle recession is more than 180 degrees, then there are increased chances of developing glaucoma. Post-cell glaucoma occurs after trauma, causing vitreous hemorrhage. So vitreous hemorrhage in long-standing cases, they can form Haynes bodies, which reach the anterior chamber through the disrupted anterior hyaloid phase, and they clog the trabecular meshwork. As long as the blade is inside the anterior chamber, post cells are not formed because there is a high oxygen pressure in the anterior chamber and a rapid circulation. But once they are in the vitreous, they tend to form these post cells, which form these, which are more difficult to pass through the trabecular meshwork. Hemolytic glaucoma happens due to the hemolysis of RBC from bleeding in the vitreous cavity. The released debris, free hemoglobin, and the macrophages laden with hemoglobin block the trabecular meshwork. Hemosiderotic glaucoma, it is caused by the toxic effects of iron on the cells of trabecular meshwork. The source of iron can be from the vitreous blade, which is long-standing, or from a retained foreign body containing iron. Lens dislocation and subluxation. The lens is dislocated anteriorly and acute angle closure glaucoma. If the lens is dislocated into the vitreous, what can happen is this vitreous can prolapse through the anterior chamber, causing a pupillary block and secondary angle closure glaucoma. Periculitic glaucoma happens through an intact lens capsule. There can be a leakage of proteins. So the trabecular meshwork is overwhelmed by the inflammatory cells and proteinaceous debris, causing a decrease in the intraocular aqueous outflow. So the common mechanisms, now coming to the penetrating injuries, what are the common mechanisms which can cause raised intraocular pressure? That is hyphema, lens dislocation, periculitic glaucoma, and host cell glaucoma. So the other mechanisms is when there's an injury to the cornea, it leads to shallowing of the anterior chamber. Thus, extensive peripheral anterior synechiae can form or inflammation can occur. Sometimes posterior synechiae can occur with the formation of seclusio pupillae and iris bombae, leading to secondary angle closure glaucoma. If there is an injury to the anterior lens capsule, that causes the lens particles to mechanically block the angle. If there is a hydrated lens with enlarged anteroposterior dimension, it is going to cause a pupillary block glaucoma and secondary angle closure.
Neha, please mute yourself.
Coming to the chemical burns, it is more common after an alkali burn. In the early phase, you see scleral shrinkage and release of prostaglandins. So it is the inflammatory response that you see in the immediate phase. In the late phase, you see a trabecular meshwork damage and peripheral anterior synechiae, causing raised intraocular pressure. Coming to the thermal burns, the cause is increased orbital pressure from orbital congestion and periorbital swelling. It is a rare entity though. IOP elevations in electric shock may be caused because of venous dilatation, contraction of extraocular muscles, and pigment dispersion. Radiation causes increased intraocular pressure by neovascularization, conjunctival telangiectasia, and hemolytic glaucoma associated with vitreous hemorrhage. So these are the pathophysiological mechanisms which occur in different types of trauma that can cause a traumatic glaucoma. So how do you work up these patients? You take an elaborate history to identify the nature of injury, see the severity of injury, if there is any possibility of intraocular foreign body, and if there is a past ocular history, the patient is already having a history of glaucoma or uveitis, then these symptoms are more magnified. We have to do a proper visual acuity assessment and inspection of globe and adnexa, slit lamp examination. Gonioscopy is important, and wherever necessary, ocular imaging has to be done. Gonioscopy is important, but it is deferred in some conditions like hyphema, where there's a risk of rebleeding, recently repaired open globe injuries, severe iridocyclitis, or painful eye. Here you can defer gonioscopy till the problem resolves. When you do a gonioscopy, you look at the presence of blood in the angle, hyperpigmentation, recession, cleft, or foreign body. So how do you manage these conditions like hyphema, inflammation, and all? If the patient is having hyphema, you provide an eye shield, ask the patient to be in a head elevated position, avoid physical exertion. You can prescribe topical cycloplegics, steroids, and non-steroidal anti-inflammatory agents. Systemic and topical anti-glaucoma medication can be given depending on the intraocular pressure. The anti-glaucoma medications that we have to avoid is pilocarpine and prostaglandins, as they can increase the inflammation. Dilated fundus examination can be done once the hyphema clears. If the hyphema clears and still there is no fundus view, then go for a B scan to see what is the cause for the decreased vision. And we can surgically intervene in cases of hyphema if the cornea is getting stained, if there is an 8-ball total hyphema or uncontrolled intraocular pressures, like 50 millimeters of mercury for 5 days, 35 millimeters for 7 days, or even earlier if there is a compromised optic. Patients with sickle cell hemoglobinopathy, they may have IOP elevations disproportionate to the amount of hyphema. Coming to the angle recession glaucoma, this is a late onset of increased intraocular pressure. you have to do a gonio in the fellow eye for comparison to see, to appreciate the angle recession. And we have to note that not every eye with an angle recession is associated with IOP elevation. If the angle recession is limited, you can try medical treatment. Prostaglandin analogs have a benefit of bypassing the dysfunctional trabecular meshwork because they can increase the infused scleral outflow. So prostaglandin analogs are they should be avoided in acute phases, but in late onset glaucoma, like in angle recession, they're useful. ELT, SLT, or NDR laser trabecular puncture, they don't have much result. Filtration surgery can be done, but that results of filtration surgery is also variable. In lens-related complications like lens dislocation, subluxation, and pupillary glaucoma, initially we have to relieve the pupillary block by doing a PI, then give a medical management and try to reduce the intraocular pressure. If it is not reducing, eventually lensectomy has to be done. So in surgery, in cases of high fever, we can try an AC washout with or without fibrinolytics. Clot aspiration can be done with ultrasonic emulsifier or vitrectomy instrumentation. The optimal time for surgical intervention in hyphema is 4 days. It allows the clot to retract properly without adhering to the adjacent tissues. Then it can be easily removed. In cases with hemolytic, hemosiderotic or cell glaucoma, we can do an anterior chamber washout or with or without pass panavision, depending on the extent of the clot. It displays lens, LIG, and traumatic cataract. As I told, we can go for lensectomy, cataract surgery with primary or secondary IOL placement. In cases where the medical treatment fails, you can go for a trabeculectomy with MMC, but the results may have there may be variable results. You can go for an ologen implant also, which is very useful in inflammatory conditions, and you can try tube shunt surgery also. Thank you. Thank you for the opportunity.
Thank you, Dr. Himbindu, for that overview on traumatic glaucoma. I know it's a very vast topic to cover in a short time. Thank you so much. Let us move on with the next talk. We are having Dr. Vanitha Pathakre with us to give us that talk. The topic is achieving low target IOP in mix in advanced glaucoma. Is it a myth or a reality? Dr. Vanitha Pathakre, she is the director, glaucoma and glaucoma services, and she's a cataract specialist as well. She heads the department at Center for Sight, Banjara Hills. She's very keen in teaching and teaching students and sharing her knowledge. And she's an expert in minimally invasive glaucoma surgery mix, innovative surgery for and also PACG, plateau iris syndrome. These are areas of interest. She's the first Indian glaucoma specialist to perform that is mix, eye stent, and she's the first to perform mix in angle closure glaucoma, and also the first to use Kahoot dual blade system to perform trabeculectomy in adults. Dr. Vanitha Pathakre has a lot of awards and publications to her credit. She has done her glaucoma fellowship from the University of Toronto. She has more than 70 publications in journals. She's extremely passionate, as I told you, about teaching and training. And she has held annual CMEs in glaucoma on World Glaucoma Day. And she's presented as invited faculty in all the international meets. She's a reviewer for several prestigious national and international journals. We are indeed happy to have you amidst us. Welcome, Dr. Vanitha Pathakre. Over to you. Dr. Vanitha, please unmute yourself.
Oh, okay. Sorry. Thank you very much for the kind invitation and introduction, Madhvi. And thanks, APOS, for this too. I will say I am a firm believer in women power, no doubt, but I also believe that we should not be losing focus, that we also compete equally with the opposite gender. Anyway, I'm going to talk about achieving low target IOP with MIGS. I will give you the setting of what MIGS is all about, and then you will understand why we are talking about trying to achieve low target IOP. So have you ever wondered why the world of neurosurgery, especially aneurysms, is moving away from clipping and going towards coiling, even though it costs 4 or 5 times more? or the world of cardiology is moving away from bypass graft, and in 1 or 2 stents is definitely 1 or 2 blockages is managed routinely by stents now, sometimes even 3 actually. And why go so far? Think about ourselves. Think about cataract surgery. We don't do such large incisions anymore unless we have complications. Our incisions are limited to 2.2 with very sophisticated instrumentation, with phacoemulsification and the uber expensive flax put into the scenario, with very, very expensive, newer IOLs, which give much better outcomes, safer outcomes. What about cornea? You have PKs, which, is still a fallback, but you have the ability to replace each layer now. So glaucoma surgical management has undergone a very similar revolution. Not many may be aware of it. So I'll try to put that in perspective. Yes, medical management is the first management. We do laser for angle closures, no doubt, and then can move on to surgical. So think about the medical approaches for glaucoma. They use natural pathways, suprachoroidal, ciliary body, and even trabecular meshwork now with the ROCK inhibitors. We know that it is the backbone of glaucoma management, but we know that more than 40% of patients require more than 2 medications, and several classes of drugs are available. It's only the prostaglandin analogs which have effective 24-hour control. Others, not so, definitely not beta blockers. One has to note that. And all have side effects. All have the ability to cause ocular surface disease. And did you know how much? It's actually more than 50%. Of course, we have done a study in asymptomatic patients and have checked for ocular surface disease in 3 groups, AGM, TRAV, and normals. And what did we find? That the OSD scores, osmolarity with the TEO lab, and fluorescein stain was all more in the anti-glaucoma medication group. The TBAT and the Shermas was the lowest in that group. Of course, preservatives also cause it through, breaking down the epithelial barrier, meibomian gland dysfunction, or effect on goblet cells. But remember, the PG analogs also have a cytotoxin that affects Tenon's tissue, and that may have an effect on your surgery. There are, of course, other factors as well, and we don't deny that. So when we have a patient like this, you can see which eye is on anti-glaucoma medication. We may ignore such slightly pink eyes. In this particular patient has undergone surgery in the left eye, and therefore only the right eye is pink. But you can no longer ignore eyes like this, which are red, which are watery, which are irritable. And not just that, hypertrichosis, orbitopathy, all these part and parcel of PG analogs. And, these are allergic symptoms that can happen as a result of any drugs, mostly brimonidine or carbonic anhydrase inhibitors. These are very common in my OPD. A 23-year-old with orbitopathy, unfortunately looking like a 53-year-old, and cicatricial changes. These are what start affecting your outcomes in TRAB surgery. Another, cicatricial ectropion. You will not believe it until you take the patient off the drugs. Nobody is pulling his lids, believe me. And granulomatous iridocyclitis, the drug, brimonidine. And really severe allergic symptoms. I have not seen anything more severe than this. And magical disappearance once you've taken the toxin off. But are these the only limitations? No, you have to have a lifelong commitment. It's like a second marriage. There are issues of compliance and adherence. There are recurring costs. And we've just talked about the side effects. It affects the quality of life of the patient, causing ocular surface disease. This not only affects quality of life, but it also increases chances of failure of surgery. And as I said, allergies are mostly due to alpha-adrenergics. So the traditional approach to glaucoma is creating an unnatural pathway, a bleb, subconjunctival drainage. Unfortunately, this can not only have serious side effects, but also failure. We want an ideal trabeculectomy bleb to be low, diffuse, posteriorly directed, as you can see in these pictures. And we want it in a recurring fashion. You want it again and again and again. But does that happen? No. Blebs do start failing in the early postoperative period, as you can see there, or they have already failed and they start looking like this. These kind of blebs are very prone to infection, as you can see in this particular case, a blebitis has occurred. So you do tend to get a lot of sight-threatening problems with filtration surgery, and the same goes with glaucoma drainage devices. And you have unique complications with drainage devices. You can have tube and plate exposure. You can have corneal endothelial touch and failure, decompensation. You can have tube blockage. So there appears to be a gap between anti-glaucoma medication and traditional bleb surgery. And this gap seems to be filled by what is now termed as minimally invasive glaucoma surgery. So it does not utilize the subconjunctival drainage route. It utilizes natural physiological pathways like the trabecular meshwork, suprachoroidal space, and the ciliary body. So physiological routes cause minimal trauma to target tissue. They have faster operating time, high safety profile, rapid recovery from the point of view of the patient. But one slight problem, there is only modest efficacy. And the reason that happens is because target IOPs are not very low because it is limited by episcleral venous pressure. So far, they have been reserved only for early disease, mild to moderate glaucoma. There are many, many devices available, and I will not go into the details, but we do have quite a few TM, trabecular meshwork or canal-based surgeries, either iStent or devices to do trabeculotomy. Suprachoroidal and mixed plus devices are not available. And of course, endocyclophotocoagulation is very much available in India. So iStent, trabecular micro bypass, generation 1 was 1 millimeter. They're the smallest ones known. It is inserted parallel to the trabecular meshwork, whereas the generation 2 is inserted perpendicular to the trabecular meshwork. Here you can see the very first iStent being done in India. You have to develop skills of intraoperative gonioscopy. As you can see there, trabecular meshwork has to be visualized, and the iStent is then gently placed into the Schlemm's canal. Once it is in the Schlemm's canal, you will see regurgitation of blood. That's how you know it is very much in the Schlemm's canal. The next one is the iStent inject. iStent inject is injected perpendicular to the Schlemm's canal. Here you can see the first one going in. There you are. And it's just being tapped into position, and then 2 to 3 millimeters away, clock hours away from it, the second one is injected. These are only 0.3 millimeter in size. So they're much smaller than the generation 1. And the second one has just gone in, as you can see there. Okay, then we have the Kahoot dual blade, with which you can do trabeculotomies. This was launched in 2015. It has a sharp tip which enters the Schlemm's canal. You have a ramp which stretches the trabecular meshwork and dual blades that cut it. You can see the surgery in angle recession glaucoma, which was just being talked about by Dr. Himabindu. Here, unroofing of the Schlemm's canal is being done. You can see a wide ciliary body band, which is angle recession. And not only do you see and want regurgitation from Schlemm's canal, but now you can see I have excised the trabecular meshwork, and I can demonstrate that on the forceps. The same can be achieved by just bending the 26 gauge hypodermic needle, which is bent ab interno needle goniectomy, which was described a few years ago. And all you have to do is bend the needle towards yourself. I bend it 45 degrees, such that you have a tip and the two cutting sides. And this particular surgery has been done with the needle. And you can see a very good appearance of the trabecular meshwork with the intraoperative gonioscopy, and the needle cutting and unroofing the Schlemm's canal just as easily as the Kahoot dual blade. But the comparison between the two, of course, is that the Kahoot dual blade is way smoother. Here we are, ECP, you visualize the ciliary body and you reduce aqueous production by using direct laser. Laser energy, believe me, is less than 1/4 that used for transscleral delivery, and the endpoint is whitening and shrinkage. And normally, I do not use it for more than 2 quadrants. So that's 180 degrees. You still have 180 degrees of Schlem's ciliary body visible. You can see the effect in angle closure, and that is what gets me very excited. Post-phaco, I cannot see angle structures, but post-phaco ECP, I can see angle structures in that very same case. Here's another example. I can see scleral spur after post-phaco ECP. So I'll just share with you some of my results. The publication is still pending. I don't want to go into details, but you can see we do get up to between 20 and 35% reduction in IOP and very good surgical success rate with reduction in anti-glaucoma medication. So now you might ask me, why combined? Now I have the opportunity of reducing inflow by doing ECP and enhancing outflow by doing trabecular meshwork-based procedures. There is no extra incision involved, and especially when you combine it with cataract surgery. And when you're not doing it in cataract surgery, all you need is a 2.2 keratome incision and 2 paracentesis, and of course, no sutures. So the advantages are all procedures are entirely ab internal, can be performed under topical or subtenons. It's sutureless, blebless, lesser or no medications, very safe, no bleb-related complications, definitely no bleb aesthesia. Rapid visual recovery, fewer post-operative visits. This is what a patient wants, isn't it? It's for their better quality of life. What are the disadvantages? Of course, you have to acquire this new skill of intraoperative gonioscopy. And if you've not been doing it in the OPD, obviously this is a challenge. And of course, many people also talk about the cost. So I will also share with you my data related to combined mix in cataract surgery. Here, more or less controlled 18.9 millimeter, but because they're advanced glaucoma, that is uncontrolled. So I get a 38% reduction and a great reduction in medication also. So whereas previously these kind of eyes, all in my hands underwent trabeculectomy along with phaco if they had cataract, I can now offer in these kind of cases combined mix. This is the doctor, 62-year-old. He had advanced glaucoma. He was on 2 drugs, 19 millimeter mercury pressure. He was not keen on starting a 3rd drug. So because he had cataract, I offered him combined mix, and now he's 6'6". IOP is controlled without medication. And what about this one? He has angle closure, 6/12 vision. So where is he seeing from? This is a macular plot. 22 pressure, 3 AGM. He had cataract. I offered him not only phaco, but I did a little bit of goniosyncyliasis so that I could do a KDB, and I combined it with ECP. And what is he today? He's 6'6" vision, pressure control, no medication. So I would summarize that though MIGs are usually indicated earlier on in the disease, and generally I will offer to every patient who is undergoing cataract surgery and is on a glaucoma patient who's undergoing cataract surgery is on 2 or more medication. It's very safe and efficacious when used in appropriate indications. Combined mix, on the other hand, it appears to be non-inferior in advanced glaucoma as well in these early results. It still spares the conjunctiva. Trap can still be performed if required. And reduction in AGM has several advantages. I've just told you, it eliminates issues of compliance, non-adherence, decreases recurring costs, enhances quality of life. So it's up to you what you want to prefer. You want an incisional surgery, or you want an angle-based surgery where the eye then looks like this, week 1, or you want to risk an eye that looks like this or can look like this post-trabeculectomy, and this is post-drainage device. So I will conclude that obviously more data is required. There's no doubt about that. But worldwide, I just attended the World Glaucoma Congress in Italy, and everyone seems to be talking about combined MIGs. Achieving low target IOP is definitely a reality. Thank you very much for a very patient listening.
Thank you so much, Dr. Vanita Patekle. It was a very lucid talk on mix. Because always, as cataract surgeons, we have seen phaco trab is the only one we thought of. So now you can go ahead with this combining with the cataract and have a later date. If at all required, we can still go ahead with trab. So that's a very good option. And there's always light at the end of the tunnel, I suppose. You have better innovations coming up and patients, because the complications of anti-glaucoma medications are really, the surface becomes so bad. The patient is not at all happy with that, and they tend to discontinue that single reason. They are more happy with the lubricating drop rather than the AGMs.
Exactly. It's becoming a big problem now, actually.
That's right. You see corneal issues, surface issues, everything. That's right. Thank you so much for that talk, Dr. Vanita. So we come to the end of the program. We have the last talk by Dr. Sja Syndrome. She has done her undergraduation from Ramchandra Medical College and her MS Ophthalmology from Arvind Eye Hospital, Madurai. She has done her fellowship also in Pediatric Ophthalmology. She's a gold medalist in her ophthalmology post-graduation. She was a consultant for entry segment and consultant pediatric ophthalmologist and strabismus in the department of in the same department in Madurai. Currently, she's heading the pediatric ophthalmology and the strabismus department at SV Arvind Eye Hospital, Tirupati. She's involved in mid-level ophthalmic personal training, and she has won award on innovation and at the national and international platforms, including the ASCRS, prestigious ASCRS Film Festival award in 2022 in Washington on her film on ergonomics in the OR. And that's all the talk is going to be now, ergonomics in the OR, enhancing the surgical performance. Over to you, Sja. Welcome, and please deliver your talk.
Thank you. Thank you so much to APOS and Dr. Madhavi Rao Garu for this opportunity. We've been seeing all of these fancy videos. Those mixed videos were so amazing, and all of these refractive surgeries. But coming back to having good outputs and all of that also depends a lot on our own well-being. So they say for any output performance, be it surgical or any other non-medical related, it depends on a person's well-being, which is often dependent on the workstation design. So this is about quality, long-term outputs, all of that depends on how our furniture, equipment, and our environment is. So now there's a lot of talk about correct posture. Now there is this term now that is text neck. They say that we all tend to look down looking at our phones. And so what happens when we bend so much is that there's a lot of pressure on our neck and upper back. And so this will cause stress and pain here. But when we sit up straight, the weight is distributed of our head. So we don't have any of this text neck. So there is also so much about what is the correct sitting posture. And maybe some of you are correcting your posture when you even look at this slide. There is also a lot about what is the correct posture to sit in the toilet. So when it says that your intestines are not pinched and when there is a better bowel movement. But what about while operating? This is where surgeons spend most of their time. But there's very little talk about this. And most of the surgeons I've spoken to at some point of that time have had mild neck pain after a long OR day. So after an OP day, nobody complains much. But after a long OR day, there is some kind of a discomfort that we all feel. So when you look at studies, and there is more and more about ergonomics being published recently, a lot of them talk about adjusting the patient's stool height, bed height, the surgeon's stool, the foot pedals, the chair, microscope, and also a lot of thing at should be a maintenance of the ergonomic focus, which basically means we need to be aware of how we are sitting. This kind of prompted us to look at a study at our hospital. Also, the other reason was that we had a couple of surgeons who would, after an OR day, need to take a leave the next day because they were so uncomfortable. So again, not much literature was available on what is the ideal posture or how is it that we are sitting. So we did this study to see, are people aware of how they are sitting? So we took photos of the surgeon during their operation. So you can see that we put a reference grid on the wall. So this was marked using a leveler, and we used the grid option on the camera. So this was a way to know that, a scientific way to know that we were using the right reference marking, and we put a sticker at the C7. So before the surgeon scrubbed, we would put a little yellow sticker on that C7 mark. So we would be able to measure the angles. And then we had an orthopedic surgeon who happened to be one of our ophthalmologist's husbands help us. So there were a lot of apps available, and he used this to measure what degree they were sitting at. So we also did a literature search to understand what is the ideal angle. So we took 4 angles. So one is the cervical angle, and this corresponds to the line drawn through a C7 tragus and the C7 straight. So ideally, this should be between 48 to 50. This seems like a very minimal thing, but this is what is the most comfortable posture to be in. And when we are flexed too much, this will cause the neck and upper back pain. So even when we text for long, we have this. So same with operating. An entire day, there will be much more. The head tilt angle is very similar to the chin elevation and chin depression that we look for in strabismus. So this is measured between the tragus and outer canthus, and a straight line drawn right through the tragus. So this is like a +7 degree. So a +7 to +15 is said to be comfortable, and anything beyond this is uncomfortable. Now the trunk angle is an angle between the C7 and the greater trochanter, something very difficult to measure in our sterile OT gowns. So this is a rough assessment that we did. So what is considered as neutral is when it is anything between plus and minus 10 degree from a 0. Too much of flexion, too much of extension again will cause discomfort at the lower back. When we looked at foot positions, it was very interesting that many of them, I'm sorry, I'm just going back a bit here. So when we look at how doctors place their foot, very interestingly that very varied foot positions that we used. What is considered ideal is when we have both our feet flat on the ground and knees flexed at an angle of 90 degree or greater. This is what is considered to be a comfortable position to be in. Now, when we asked surgeons how they are sitting, it's very difficult to say, I'm at 90 degree, I'm at 30 degree. So what we did is we gave them these photographs and asked them to click, what do you think you were sitting at most of the time while you were operating? And then compared it with photos that we took at various intervals during their surgery day. So we took multiple photos to compare. 18 surgeons who had experience from 3 to 20 years were included. 17 of them complained of pain, usually on the milder scale below 4. 1 exercised regularly, 4 walked regularly. And of all of these, only 2 were right about the neck posture that they were sitting at. So 16 were not right about, comparing their photographs and what they thought they were sitting at, they were wrong. 5 were aware of how they placed their legs. 65% were right about their trunk angle. So when we looked at the neck position, we found that nobody was sitting at what was considered the ideal neck angle, and about 64% complained of some kind of a neck pain at the end of our OR day. And when we asked what is ideal, only 1 was able to answer correctly. So we gave an evaluation report at the end of this photograph comparing what they were sitting at, what they were actually, what was ideal. But the idea was more to just create an awareness. There's no correct thing that you can fix everything, just that the surgeons become more aware on how they are sitting when they operate. So when we sit in the OR, it is very important that we first adjust, at least at the beginning of the first case, at least we need to be very aware that we do things right. So we adjust the patient's height often. We also need to adjust the surgeon's tool and adjust the microscope. So in some microscopes, this can be done sterile. In some, it is the assisting can do it in an unsterile way. So often when the tilt is not easily done in a sterile way, we look for the assisting or we just accommodate to that. It's very important to fix this and be comfortable. We also need to adjust the eyepiece to know that we are at the right angle. So when you look at this picture, it looks like she's sitting comfortably, but her neck is actually extended. And you can see that her eye level is a little off. And especially with this extension, we get neck pain much easier. So bringing the scope down, adjusting the eyepiece, you can now see that her eye level is much more comfortable. So with this, you will not feel a stress setter when you're operating in this way. So this was an interesting study which looked at the SICS learning curve. So what they did was look at how experienced surgeons hold the instruments when they are operating. So what this study says is if you start learning to do this even from the beginning of your learning curve becomes much smaller. So So this is not about just doing better surgery. It's also about ergonomics, how you are holding your hands. So you can see in this, when we do phaco, it is important to rest your 2 fingers. So we use 3 fingers to hold the phaco, any of the steps, be it holding the side port or at the second instrument. 3 fingers are used for holding the instrument, and the 2 fingers below are usually rested. So it's good to rest them either on the patient's cheek or the forehead. And you can also see that those with longer fingers would tend to flex it here. Again, this is something we don't learn in the beginning, but subconsciously we start doing it. It's good to be aware even when we start learning surgery. So when we hold the second instrument, 2 fingers above is to use to hold the instrument, and the one below is to maintain stability. So when you move it above, it allows for more movements, but if you want to be holding it more stable, we hand stability. So same with all of the machines that we, any of the instruments that we handle. So this is also a video taken from the side view to show in both hands how we flex these 2 fingers and the other 3 fingers used to stabilize. So it is important when we start the OR, at least in the beginning, to be correct in the correct position, and then to keep adjusting whenever we shift between patients. Having said all of this, it is not about ideal posture, because static posture, no matter if it's good or bad, is not ideal, because movement is critical to our health. So the concept now is that movement is medicine. And so we talk a lot about what is the right good flexions and extensions and exercises to do. We have put this up in our changing room. So it's just a reminder, like, remember to do some exercise. And I think in this Women's Ophthalmic Society, it's good that we are talking about this, that we pay attention to our own health. And this is a poster we put up in our operating rooms. Very simple poster, but it's just like a reminder when you're between cases or have a thing, you just glance at it, you remember to do some kind of a neck flexion or something. So I would like to end to say, take care of your body. It's the only place we have to live. Thank you so much once again for this opportunity.
Thank you so much, Dr. Satya. It was such a nice talk, like where we take so many things for granted. Our position, posture, finger holding, everything becomes, at that point, it's more critical that you do the surgery properly. You don't take care of your posture. And in the long way, probably we pay a lot because of that. So it was a very nice talk. So nice. I really enjoyed this. I think we have come to the end of our sessions. All the speakers have given such lovely talks. Some of them are inspiring. Some of them are eye-openers. Welcome, Dr. Madhu. I think Dr. Madhu is there. He's our chairman, scientific committee. Madhu, can you add some points or give a concluding remark to our program?
I have been following it on YouTube, ma'am. You asked me to come back, so I came back here. Excellent talks by all the speakers, and I thank all of you of the Andhra Pradesh Ophthalmic Society for taking your valuable time on a Sunday. And I congratulate Madhavi, ma'am, for designing this program so well. There is a good mix of clinical and other non-clinical subjects too in this talk. Congratulations, ma'am, and congratulations all the speakers. Have a great Sunday. Thank you once again on behalf of Andhra Pradesh.
Thank you so much, Madhu. Thank you for giving me an opportunity to conduct this. I was quite excited right at the beginning when the title was Women Power in Ophthalmology Make a Difference, Positive Difference. So that's exactly what all of you have done today, this morning. Thank you once again for spending your valuable Sunday morning time. I know I got a message from Dr. Chaitra. She was preparing breakfast for her children. In between, she logged in, she gave her talk, she logged out. That's how, as I told, we can multitask it with real ease, I think. So thank you once again. Dr. Subhadra ma'am, would you like to give some concluding remarks?
Nothing, just be good, enjoy. Everyone did great. And, there are a lot of lessons we learned and new things. And I think the beauty was that we wove in our lives and important things of our lives into the scientific work, which is what we should do in our day-to-day life also. It should not be like balance, like either say low, the other. Weave it together, then it becomes really wonderful tapestry of life. Great, yes. Great, wonderful.
Thank you so much. Thank you one and all. Have a great Sunday. Bye-bye.